Good morning. My name is Alan Weil. I'm Editor-in-Chief of Health Affairs. We're really excited today to have this forum entitled Securing the Future of Value-Based Payment. This is a follow-on to a forum we did some time ago that covered some of the same topics but in a rather different environment. And of course, while the coverage provisions of the Affordable Care Act are very much in debate, it is often said in this town that everyone agrees on the move to value, moving away from volume, the need for focus on improving the delivery system, that's not a partisan issue. And that is true, and yet just because it's not partisan doesn't mean it's not complicated or controversial. And our goal for today is to help keep the progress moving forward on this critical issue, on this critical goal, by hopefully focusing in on its complexity in ways that enable people in a positive way to adopt policies and make changes that further the agenda of more efficient, more effective healthcare system. We're able to have this forum with support from the Commonwealth Fund. We're very grateful for their support for the event. We also have support from the Federation of American Hospitals, and I want to acknowledge that the Federation also was a lead sponsor in the prior event that we did on this subject, and therefore this is a follow-on from that. We had hoped, of course, to have a high-level official of some sort kick us off. We extended invitations. We're unable to secure the speaker we might have wanted, so you're stuck with me for a couple of opening comments before I start the panel. The challenge I think we face with the concept of value-based payment is that it sounds so good you can't be against it, but that doesn't really mean you're for it. And like many things that sound good, part of why they sound good is that everyone maps their own image of what the it is, and they often gloss over the different ideas that underlie the thought or the concept. It reminds me a lot of managed care. I mean, who's really for unmanaged care? But how we manage care or coordinate care is actually very complex. And the same complexity underlies the concepts around value-based payment. Who wants to pay for value? Who wants to pay for volume when you could pay for value? Of course, it's better to pay for value. And yet, behind that very catchy and appropriate phrase are an exceedingly long list of complex issues. Some of them have to do with measurement, which we will focus on in our third panel. But there's also very thorny issues around compulsion, the speed of change, compulsion on the provider side, compulsion on the patient side, or incentives on the patient side, or incentives on the provider side. There's the notion that if we want to pay for value, how do we encourage value or reward value? My arithmetic tells me that if value, roughly speaking, is quality divided by cost, then if you pay more for high value, you by definition reduce value because you've increased the costs. Let me try that again. If you pay more for something because it's cheap, it's not cheap anymore. And so we can't reward value just by giving it more money, or we're undercutting value. At the same time, we want incentives for improvement. And as with anything, think of an employee, you want to encourage and reward improvement as you also encourage and reward high performance. And you have an incredibly heterogeneous system out there. And so how do you really measure and reward and provide incentives? There are many, many more issues like this. My point only is to say that we, as a healthcare sector, if we want to pursue a value agenda, have to uncover these issues and figure out how we're going to approach them and address them. And the role of government is a critical variable in this, both with respect to its leadership as a purchaser and its ability to be a regulator and its ability to be a convener and a force for change. And of course, here in Washington, the question of the role of government is always central. So hopefully at the end of this morning, you'll feel some progress in your own mind, and maybe as a health community, we will feel some progress in understanding the issues at stake and also understanding some paths forward on the issues that I mentioned. We're going to start with a panel on physician payment. When we had this last, I think the regs had, or a draft of them had just come out, and so they were hot off the press. We're a little further along in looking at Medicare's value-based payment approach for physicians. The second panel will be focused on hospitals, where we have a longer history and more evidence about how some of the value initiatives have played out thus far. And then, as I noted, we'll focus in on the question of measurement, which is central to the entire enterprise. If we can't measure it, it's going to be pretty hard for us to reward it. And so with that, let me just say that in each panel, I've asked our panelists to make a few minutes of opening remarks, more than a few minutes, but to try to keep them brief. I'll follow up with some questions of my own and then open it up to you in the audience. And hopefully we will have a robust conversation with some areas of disagreement, I am sure, as well as agreement. In our first panel, you'll hear first from Kate Goodrich, who's at the Centers for Medicare and Medicaid Services. She's the director of the Center for Clinical Standards and Quality. Mark Miller is the executive director of MedPAC, the Medicare Payment and Advisory Commission, which advises Congress on Medicare payment quality and access. Bob Berenson, an Institute fellow at the Urban Institute, where he's been since 2003. He was for 3 years on MedPAC, as well as serving as vice chair for 2 of those years. And Darilyn Moyer, the executive vice president and chief executive officer of the American College of Physicians, which is the largest physician specialty society and the second largest medical organization in the United States. So I will begin by turning it over to Kate.
All right. Thank you very much, and thanks for inviting me to be on this panel today. I don't know if I have slides up or not. I had sent in some, but I sent them in late. I can, if it's okay, I'll stay here if that's okay.
Other way.
Other way?
Sorry, no. Sorry.
There we go. That looks familiar. So yes, I'm Kate Goodrich. I am the director of the Center for Clinical Standards and Quality and have primary responsibility at CMS for implementation of the MIPS program, but I do oversee sort of the whole quality payment program enterprise, from operations to our portal and communications and everything else, and of course work closely with Patrick Conway, Amy Bassano, and others at the Innovation Center. So I'm just going to give you a very broad overview of the quality payment program and sort of some of our strategic objectives and how we approached the first year of the policy making. Fundamentally, MACRA's goal was to reform clinician payments and incentivize movement into alternative payment arrangements, known now as advanced alternative payment models. There's 2 tracks. The merit-based incentive payment system, which is based upon the fee-for-service system and has a multiplier up or down in the first year of 4%, and advanced APMs that have the requirements of leveraging certified EHR technology, using quality measures, or basing payment on performance on quality measures, and of course bearing more than nominal risk. We anticipate that in the first year of the program, we are in the first year now of the performance period in 2017, that we'll have between 70 to 90,000 clinicians, eligible clinicians, who will be in advanced APMs and will be what are called qualified participants, so they'll get the 5% bonus for being in an advanced APM, and that the rest will be in MIPS. So the majority of clinicians we anticipate being in MIPS. Of course, a significant portion of clinicians will fall below the low volume threshold that the MACRA legislation allowed and will not be participating. MIPS, of course, assesses clinicians on quality, on cost, improvement activities, clinical practice improvement activities, as well as use of EHR technology, what we call advancing care information. And their scores in each of those categories will be combined into a final score, arrayed on a 0 to 100 scale, and then again, payments will be adjusted up or down. And it's a budget neutral program, but in the first 5 years, there's $500 million per year for each of those years for what's called exceptional performance. There we go. When we started off designing the program, we laid out several strategic goals. We interacted extensively with the clinician community, also the patient and consumer community, and these strategic goals really come from all of them. Obviously, number one is to improve beneficiary outcomes, but I just want to highlight a few more. Number two, I think, is to really try to improve the clinician experience with the programs. What we heard from folks is that the legacy programs are too much one size fits all. There needed to be more flexibility to account for the variation in scope of practice. Many of our programs were felt to be very burdensome and confusing, so we've really tried to focus on streamlining and making things more understandable, and also providing technical assistance to clinicians to help them to be able to successfully participate in the program. We obviously, as the law requires, but want to increase the adoption of advanced APMs and move more clinicians into that space. And then finally, we really have been focused heavily on improving program operations and implementation. And the law actually gave about $80 million a year for 5 years to help us be able to stand up the programs. And so that's been a major focus for us as well. What we heard from clinicians when we put out the proposed rule that Alan mentioned last year in April really reflected the diversity of opinion that's out there even within the clinician space, but there were some very loud overarching themes. I think the two big messages that we heard were people needed more time to understand the program and to get ready for the program. That's number one, and related to that is a real concern for folks who were in solo practices, small practices, and in rural areas, and their ability to be successful in the program. People really felt that the program was going to really harm those practices, move towards more consolidation, and really those folks would have a hard time being successful because they lacked resources. However, not everybody had that opinion. We definitely heard from some folks, particularly folks who'd been participating in the legacy programs, that the way we designed it in the first year with Pick Your Pace, which really made it easy for folks to avoid a penalty, actually meant that the amount that people could earn through bonuses was going to be much smaller, and they were disappointed in that, given the time and resources that they had invested in their practices to be successful in the programs. And then people also wanted more time to bring on more advanced APMs, which we think we'll be able to do in 2018. So the advanced APMs that are available in 2017 you see listed here. We do anticipate that through the efforts of the Innovation Center, but also the Physician-Focused Payment Model Technical Advisory Committee, or the PTAC, that we'll have more of these available over time, including in 2018, when we're estimating that we'll be able to 1.5 to double the number of clinicians that will be participating in these advanced APMs. So what's next? We are currently working on the year 2 proposed rule. What that means is that I'm very happy to answer your questions. I probably can't get too specific about what we're planning for the next year, but we are working on that right now. I will highlight for you a few features of the upcoming rule. Number one, we will be making proposals around virtual groups, which is something that clinicians have very much wanted to see brought on. I think we're disappointed that we weren't able to do that in the first year. We also will be making proposals around scoring improvement from year to year, as the law requires that we do, as well as plans for all-payer APMs. And then finally, just to highlight, at least what I consider to be the main challenge of this program, which is that the clinician practice is very diverse. And what that means is that finding ways for the program to be flexible to meet the needs of the variation in practice that is out there is a challenge. And one of the things that we found as we were developing the first year rule, and it's true as we're working now on the second year, is you always have to make trade-offs. And often what that trade-off is between simplicity and flexibility. And within all of that, of course, as Alan mentioned, is a lot of complexity that is inherent to the law, inherent to the programs, and that we continue to try to work through. And what that also means is that this program, these programs really are going to evolve over time as we continue to ramp up and learn through implementation and continue to hear feedback from folks. So I will stop there, turn it over to the next speaker.
Mark.
I don't know if you need that or not.
Yeah, I don't know either. I think I have a slide, but yeah, there's a slide. One thing about a 7-minute talk is you can put it all on one slide. Doesn't make it clearer, just it's on one slide. All right, so there's a few things. A couple things that I want to say. The inherent complexity of the law, which Kate just mentioned, is something that motivates my comments, and the notion of evolution will motivate the comments. So, obviously macro was designed in order to get out from under the SGR, and the commission was, involved in trying to get the SGR retired and to move in a different direction. The resulting legislation, the commission has started to work through, and of course what's frustrating for everybody in trying to deal with what's right in front of them is we're already thinking about, next steps down the road. And there's a few things that I think thematically have concerned the commission. And again, this is about, I think the design of the law. There was great concern that it would be relatively burdensome, that the signals weren't necessarily clearly aligned, and to kind of flesh some of that out. Particularly in the MIPS environment, there's concern about collecting data, mountains of data at the individual practitioner level, and the notion that many of those measures are topped out. They aren't direct accountability types of measures. In some instances, the provider is choosing their own measures, which creates comparability issues. And so the net impact is a concern that we're collecting a lot of data. That data may not be particularly well designed to distinguish among performance among providers, which is a relatively common theme in Medicare physician measurement. There's always this dilemma of trying to measure at the individual physician level because everybody wants to be measured for their own work, but then it becomes so noisy, you think about measuring at the aggregate level, but then the individual performance is lost, and we're continuing and will continue to kind of work back and forth between those two poles. And anyway, the net is that a lot of burden, maybe not a lot of signal coming out of it. As other people have said, a real sense that they want, the commission wants people to move from MIPS, the fee-for-service environment, to more of an alternative payment model environment. But even in the alternative payment model environment, the notion being that you don't just sit in, say, a one-sided risk situation. You take true risk, you take responsibility for the patient, and you keep moving through that. And then, as Kate said, a similar concern of can everybody play? Large systems, which have enough resources to take risk, but smaller practices who may have some restricted ability to take risk. So that brings me to this slide. And so what I want to emphasize is this is where our discussions are. We do everything in public, talk about things. All of this has been discussed in public, but we have not made recommendations. So I want to be clear that this is just a discussion. So think about things this way, and I'm sure this will give Kate a heart attack as she's trying to implement what's there, and the notion of redesigning things. Think of MIPS where you say you will not collect individual provider information. Instead, you calculate population-based outcome measures like avoidable admissions, avoidable ED, that type of thing. You take a withhold from the payment stream, enough of a percentage that you get people's attention, and say you have a few options as a provider. If you don't want to do anything, if you just want to be in fee-for-service and you're fine with the withhold, you don't have to do anything. Secondly, you could create a virtual group. I want to be measured along with these providers, and the group has to be large enough that you can detect a signal on those population-based measures. Or third, you say, I'm going to join an APM, you get your withhold back, which leans a bit into the APM. Also leaning into the APM, and Kate mentioned this is a feature of the law, is $500 million in exceptional performance was put in on the MIPS side. The commission is discussing maybe it shouldn't have been there, maybe it should be paid out on the APM side, and you use those extra dollars to structure asymmetric risk corridors where you have more upside. But of course, if there's more upside, that always means the government's taking a greater percentage of the risk, and you use some of those dollars to indemnify the government in that situation. With respect to APMs, some of the principles that the commission's discussed was the notion that you get reward for performance rather than participation. There was some surprise, I guess, on the part of the commission that you get your 5% on your whole book of business if you hit the revenue target, even if the APM wasn't particularly successful. And I think that that's something that there was a fair amount of discussion about. The notion is that the risk is for the entire experience of the patient. They very much have this idea that that we should be thinking about the entire patient and coordinating, and that's why there's some concern in the MIPS world of measuring individual provider and individual services. And then some discussion of eliminating the revenue cliffs and saying instead of 25, 50%, you get your 5% add-on for each dollar that travels through the APM. More dollars in the APM, more 5% add-on, and you kind of work that way. And then the idea is that if you go into a two-sided risk, there's a certain amount of regulatory relief, and while I don't have time to discuss it, we also have some ideas on how to incent the beneficiary. And the last few comments are structuring the risk. We would say that you always judge performance on total outcomes for the patient. Again, sort of trying to get the coordination idea. But that large systems take risk on the entire benchmark. Smaller practices take risk perhaps on the percentage of revenue that they have involved in that benchmark. But it's two-sided risk. It might be asymmetric, but again, performance judged on total outcomes for the patient, which are models that Kate and her colleagues have been discussing. The last thing that I'll say, and just to bring us back to something that's off point from everything that I've been talking about, is the Commission also, at the time when we were thinking about SGR reform, we were also thinking about fee schedule reform and continue to believe that the fee schedule has this imbalance which favors procedural services over cognitive and primary care, and has continued to talk about the notion of reforming the primary care end of things and paying rather than on a service basis, the notion of trying to pay more on a per patient basis in that space. And I'm at time, and I'll stop there.
Thank you, Mark. Bob?
Oh, yeah, sure.
So I will take the prerogative of standing. So let me see if the forward works. Did I go backwards?
Yeah, I think we
went
did.
backwards.
There you go.
All right. So first I want to do a disclaimer. I am also a member of what's called PTAC, and I actually have to read what it is because it's hard to remember. The Physician-Focused Payment Model Technical Advisory Committee, which was set up under MACRA as a quasi-independent commission. We actually sort of work, ASPE at the department is who houses us basically, and we were added to MACRA because of a perception in the physician community, especially amongst specialists, that payment models for specialists have not been given enough attention, and we are one of the phrases used is we are going to help round out the portfolio of payment models that CMS should be testing. So we have started. We've actually just last week reviewed some proposals, and my disclaimer is that I am not here representing PTAC. I'm here on my own, and some of my views may not be representative of some of the individual members of PTAC. So I think you can all see this. Yes, this is the simple slide about alternative payment models. This was developed by the Learning Action Network, which works with CMS. The original framework, I understand it's being reviewed and perhaps revised at this point, but it follows a very broad notion that has been afoot for a decade in health policy, that payment reform can follow on a continuum, with the far left being just fee-for-service with no relationship to quality and value, and then it moves to add performance measurement in the second category. It then moves towards population-based payment, but is still built on fee-for-service, but now has financial incentives embedded in it. starting with shared savings, but moving to shared risk as well, and ultimately winding up at Category 4, which is called population-based payment, and two prominent examples, one of which would be condition-based population-based payment, paying for a condition, a year's worth of treatment for congestive heart failure, something like that, or ultimately comprehensive, what we used to call capitation, but that's a dirty word, paying per member or per person per month in a risk-adjusted format and holding an organization accountable for quality and spending. There actually are 28 subdivisions in a more elaborate slide. I spared you that. I just want to make a couple of points here and then move on. And well, one major point here, and I'll be referring back to this in a moment, even at level 4, fee-for-service, the Medicare physician fee schedule is sort of the architecture on which all of these things are built. So let me come back to that. Let me try to go forward. Where am I? There we go. So some observations about this framework. God, I didn't think I needed glasses, but I'm beginning to. All right, it emphasizes theoretical incentives in payment methods. And having worked in my past at a health plan and at CMS in the Center for Medicare, what was the predecessor to the Center for Medicare, the design and operational issues often determine the success or failure of a payment model. So we can have very elegant incentives and have risk, but how does it work on the ground? That's point one. And so I would say that the assumption that the value derives from using quality measures and financial risk-bearing is only part of the story, and in fact, I would argue that you can have more or less value, and this is the last bullet, I even put it in boldface, more or less value in any payment model based on the design and its operational characteristics. And so I think it's not particularly helpful to sort of have this continuum. It's useful as a descriptive tool to sort of locate a payment model for descriptive purposes, but many countries actually get a lot more value out of their fee schedule because of how they construct the fees than the US does. And in this case, it's particularly important because most of the new payment models, the alternative payment models, are built on a fee schedule. So you need to fix the fee schedule if you're going to get the value out of the alternative payment model. Let me give you sort of a real-world example of how just labeling something value-based because it's got some performance measurement and some risk-bearing can be misleading. I spend some of my time reviewing the issue of market consolidation, concentration, and was reading a district court's opinion about a proposed merger of two hospital systems in the same town. And the judge, relying on testimony from one of the witnesses, said, the government is now paying 50 to 80% of payment for value, so we don't have to worry about prices anymore. Is basically what the decision was. It used to be that judges said if a hospital is not for profit, that means it will be in the best interest of the community and can't possibly be raising its prices. We've learned that's not right. We used to think that if the hospital had board members who were from other sectors, including those who were paying for health care, they would police the hospital's practices to raise prices. That's not right. And to just label, oh, they're being paid through value as a protection against raising prices, well, that's not right either. And so to finish, let me give you just a few examples of what I would consider crucial design or operational issues that will determine success of what are very appealing theoretical models of payment reform. So a procedure-based bundled episode. Think of a hip or knee replacement. One of the issues that one really wants to know is, are these procedures appropriate for the patient? And indeed, does the payment model create an incentive to even have more, perhaps marginally or not appropriate interventions? To simply measure the per case spending, the fact that under the bundle you save money within the episode is not sufficient. It's useful. You want to know what's happening to the volume of services, and not just for that institution, but across the community. Because you could make a case that there's a redistribution of procedures to this focus factory, or you could say there's physician and hospital-induced demand for unnecessary procedures. For condition-based episodes, which is in category 4, you want to know, do you have a really crisp definition of the condition? What I've learned on the PTAC is that for general reporting, most Medicare beneficiaries have most conditions. It turns out, like 40% of them have arthritis, 60% of them have hypertension. I don't know if that's exactly right. Well, when you're paying for a condition, what are your definitions? How do you make sure you don't get what I've called the woodwork effect of conditions appearing out of the woodwork? And then finally, for population-based payments to an ACO or the like, can risk adjustment actually work? We have ongoing problems with risk adjustment for Medicare Advantage plans, and they're one step removed from the actual coding. When you start doing population-based payment at the level of the doctors, what protection do you have operationally that the risk adjustment can be monitored and made to work? And with that, thank you very much.
Good morning. Thank you for inviting me today. I'm Darilyn Moyer. I'm the relative new kid on the block. I've been helping to lead the American College of Physicians for about the past 7 months, but I still maintain seeing patients on a part-time basis in a primary care internal medicine practice with the internal medicine residents at a large safety net hospital in Philadelphia. Let me tell you about a story of a patient that I saw recently. She was a middle-aged woman, and it seems like middle-aged, that age keeps going up as we age, who had multiple medical issues, diabetes, hypertension, was on a blood thinner, had come in with a fairly brisk and profuse vaginal bleeding, had a history of fibroids. And upon questioning her more, we realized that what was going on with this patient, this had been going on for about a year, was that she was taking some nonsteroidal anti-inflammatory agents because she had a cracked off tooth that she was trying to seek some additional pain management for, did not realize that it interacted with her blood thinners, came in with these recurrent issues, and could not get care to get the tooth taken care of. That was really basically triggering all of this. Couldn't afford it because she was paying too much for her insulin to treat her diabetes. We rapidly assembled our team, and we are a patient-centered medical home, and got our social worker and our pharmacy D doctors and activated our dental school, and were able to, I think, affect significant impact for this patient. And I'll tell you at the end what the most satisfying part of seeing that patient was. So the ACP is the largest medical specialty organization in the United States. 25% of the practicing physicians in the U.S. are internal medicine physicians practicing in primary care, hospital-based care, or subspecialties of medicine, of which there are about 20 subspecialties of medicine. We are sort of doctors. We apply scientific knowledge through all phases of the adult care cycle, prevention, treatment, diagnosis, et cetera. And we also are very engaged in patient partnership in healthcare. We are the only major physician organization that has patient partnership in healthcare that really infuses at every level, organizational level, to the devil in the details of what we do. What impact is this going to have on patients? So as Potter Stewart famously asked, in this case it was about pornography. This case it is, how do you know excellent primary care and excellent care when you see it? How do you pay for that comprehensiveness, dealing with complex patients, communicating, that continuity of care, that collaboration that has to happen in the background to not pay for that patient to get admitted with an exacerbation of their heart failure or their diabetes out of control? Well, it really needs to start at the basic educational level. We do a great job in this country of teaching our medical students medical knowledge and clinical facts and implementation. What we need to do more of is start at the very beginning levels of medical education for all of our healthcare workers to understand how to deliver care in teams and how to improve patient care. Whenever you talk to physicians about value, frequently they shut down. And whenever you throw a lot of data at them without stories, they will shut down. But if you talk to them about how to improve patient care, how we make this better, that's what we want to do. We all want to bring our best to patient care every day. We are very concerned about the administrative burden that is leading to an epidemic of decreased professional resiliency and satisfaction. And so the ACP has a Patients Before Paperwork initiative that has basically touched all the areas of our organization, from medical education to medical practice and quality to health and public policy and to practice transformation. We really want to study these educational gaps and how we can make practice better for the patients and the physicians and their teams of care. We really want to see that the data get to a better, more harmonized, synergized, simplified flow in a patient visit. Right now, we're seeing basically for every minute that a doctor spends seeing the patient face to face, they might be spending 1 to 2 additional minutes on electronic health record work and paperwork to affect the change that we need for that patient. So challenges on the ground are the educational system. We spend a lot of time educating our new doctors about the EHR and about all the check boxes they need to check off. What we really need to do is feature how to make a difference in terms of affecting change at a system level from their colleagues, from their peer colleagues, from their other colleagues. One of the phenomena that has happened with the siloed fragmentation of our health care and basically doctors not going into the hospital as much and that intense time pressure is that they don't get to talk as much as a community. They don't go and sit down and have lunch together, where you have the specialist educating the primary care doctor about why you don't need to, for example, order a scan with contrast for a patient with a lung nodule, or what the treatment course is duration for somebody with a blood clot. We need to foster that sense of community more. Physicians have a lot of intrinsic motivation to do better, mastery and purpose, bringing meaning to patient care and wanting to bring their best. They also are naturally a little bit competitive and they want to know that they're performing well. We need to get away from the administrative jiu-jitsu that we put people through. It's interesting when you think about how the problem with anesthesia machines was solved. Used to be that there were a lot of bad patient outcomes because all the buttons were different and doctors didn't know how to operate one anesthesia machine from another. And what was done was that it was standardized, simplified, and harmonized. And that's what we need to happen with the administrative challenges and with the measurement as well. Luckily, physicians are going to put up with a lot before they throw in that stethoscope. So trying to get to systems that appeal to that natural leadership for physicians and their teams is going to be important. We want to know, physicians and their teams want to know, why are we doing this? How is this going to translate to better patient care? And what are some examples of what has happened? When we have medical students and residents, we need to spend as much time talking about how that idea about, we couldn't get our patients to go to the ophthalmologist to get their retina examined for their diabetes, but we put a person who came into the practice who started to do retinal exams in the practice and transmit them digitally to the ophthalmologist to find out who needed follow-up with the ophthalmologist, to make sure that we could get that person the care they needed. The physicians identified the care. And in summary, we really need to get back to taking care of patients, getting back to that primacy of the physician-patient relationship, the patient-physician relationship. What happened with this patient that I told you about at the beginning, that we were hopefully able, with about 2 hours of what I call ambulatory intensive care, able to pull all of the coordination, the communication into the system. And the best thing that happened was, as I quickly ran out of the practice to get to do my next task for the day on a very cold day last month, I heard this, "Hey, Dr. Moyer," and that patient was there sitting in her car and said to me, "I want to thank you for helping me. Thank you to you and the team for helping me today. I feel really a lot better, and I think that something is going to be impactful for my care." And so that thanks for me was the best thing that happened that day. Thank you.
Well, that's an excellent introduction and coverage of the topic. I'm going to ask a few questions. The one that just stands out first, and it as I listen, as each of you go down the line in some kind of an order, is the question of whether we're sort of trying to over-engineer our solution to this problem. I hear, signals on the ground and how much the system can absorb, and then there are these incredibly complex technical issues. And I'm wondering, is it possible to send, I guess the question for me is, do we want to engineer at a level of detail that we're sending these very, what sound to me like micro signals out to the delivery system, tweak this, turn that, or do we want to send more macro signals? And obviously, I suppose the answer is we want to do some of each. How are we doing in balancing that so that we're not trying to use payment policy to completely engineer the system? Who wants to take on that question?
Mark does.
Thanks, Bob. No, I do actually want to take that question, because, and so I wish I had thought about it to say those, because in some ways I think that's what the commission is trying to say, is to try and get out of the underbrush, send macro signals. So think of a population-based measure that says, from a program point of view and allocating resources, this is what the program's looking at. Then the notion underneath that and a set of providers want to come together, organize, use EHR, use their own quality metrics internally in order to manage the care. That would be more the notion, instead of trying to get down into each and every service and each and every provider. So I think that's some of the notion. And similarly, in the APM world, the notion of two-sided risk, then you can start to back off of regulation, because, when you think of a lot of the regulatory requirements, they're in the fee-for-service environment to control the tails of the distribution, where people start to engage in abusive practices. But if you're taking risk, then the program can back off there and say, okay, you're now managing the risk. You want to put somebody in home health who doesn't strictly meet the home health definition, but you think it's the right move, then you start to do things like that. So yeah, that is what I was trying to say. Thanks,
I'll jump into between the two gentlemen. The ACP recently released a paper called Putting Patients First by Reducing Administrative Tasks. And it really asks the questions and puts a framework around what is the intent of this task? What is the purpose and intent? What is the effect? And what are the potential solutions? We find that and when you've seen one practice, you've seen one practice, and that by allowing the people on the ground to feel that they are engaged and they have the power to be the levers of change, that you can really start to look at all of the administrative tasks with that framework and start to streamline them and get back back to taking care of patients and putting them first. I think that the other big area is the entire social determinants of health and how that weighs into and the attribution for that as we take care of patients in terms of managing patient populations and starting to not just think about the patients that are right in front of you that are in your practice, but what about trying to get out to all those patients that haven't been coming in that you know need to have their care managed, and to allow those granular grassroots ideas to facilitate that and to allow that to grow into improving and translating into better value.
Just very quickly, I guess just a couple of points. One is it's a very important question for which I don't think there is any consensus at this time as to whether we should be doing lots more testing of lots more models or whether we have to now begin to hone in and focus. I tend to be more in the latter camp, but on the PTAC, we are getting letters of intent for the most interesting ideas at a very micro level. I think you used the word micro. This is probably not one, but left arm pain might be a payment model that we would need to develop because there's something unique about left arm pain as opposed to something else.
Like right arm pain.
Like right arm pain. And so since I'm coming from a former life at CMS, administrability strikes me as one of the issues that, again, hasn't gotten quite the attention. One can come up with very elegant payment models for this or that, but how do you sort of scale it up nationally and allow CMS and its contractors to actually manage it? And I guess the other point I would make is that at some point, my view is that we need to move on to some mandatory testing rather than everything being at a voluntary level. But I think we have a secretary who doesn't support that, and so I'm not sure where we're going to be at the end of just voluntary testing when first movers and early adopters decide to test something out, but we don't really know how it applies broadly in any community. So I think we don't have a direction at this point.
The last thing I'll add, I want to tee off of what Mark said. So I actually don't think the MedPAC idea with population-based measures is crazy. It doesn't give me chest pain.
It's only you.
However, I think there are some practical issues to think about in that context, right? So I think if you could focus on sort of a core set of claims-based or patient experience type population level measures, that could really help move the needle if you sort of give everybody the same signal. I will say what we've learned through the so far implementation of the program is that clinicians do feel very strongly about being measured on the kind of care that they provide. An electrophysiologist will want to be measured on outcomes for the patients that he puts pacemakers in, right? And that sort of thing. So I think there is that natural tension between really important population level outcomes like readmissions and ambulatory care sensitive, acute care days and that sort of thing. But there's also we believe that clinician engagement and buy-in into the programs is going to be really important for the success writ large, which I think means also ensuring that they are being held accountable for the things that they also feel are important, that are outcome-based, that are patient-reported outcome-based. So thinking about that tension between those types of measures is, I think something we'll be doing a lot of.
So we have a whole panel on measurement, and a lot of these issues I hope we will continue into the later morning. But I want to turn away from that for a moment and ask about the relative roles. So the focus is very much, of course, on payment and payment policy. We had a nice presentation about the role of professionalism and professional associations and the role that can play. And then, of course, once you start aggregating some of these payments up, you get a question of scale and the institutions where people work, whether it's a hospital, an academic medical center, a group practice, or the like. So my question to the four of you would be, are we trying to get payment, or I'll put it this way, how do we align the goals we are trying to achieve through payment models with the goals that are best achieved through institutional investments, whether it's professional societies or delivery systems? How do we channel those in the same direction?
Well, I mean, I think you need to talk to the people on the ground. We have a very big initiative through our high value care collaborative, our council on subspecialties, where we try to facilitate those conversations. We developed a high value care toolkit, actually, by sitting down with primary care doctors, hospital-based physicians, and the consultative physicians in the world of medicine to say, okay, what do we need to do in terms of the general premises that we need when we're referring a patient? How do you formulate the clinical question? What is the information you want to get back? And you want to include in sort of that information system in that clinical system, and vice versa. What do the primary care physicians, the hospitalists, need from that system? And then actually putting together templated condition-specific criteria for what that looks like in terms of who is expected to do what with patients with various conditions, and also understanding patients don't just come in saying, I have one diagnosis, and that the complexity needs to be embedded in that. But that at least gets that conversation started so that people feel like they're less siloed and more community-based.
So let me tell you where I'll take that question. A couple years ago, Tom Rice and I wrote a paper in which we argued that instead of trying to figure out how to get the right financial incentives for people at the center, like in Washington and Baltimore, to get those doctors and hospitals to do what they should be doing, we should rather be moving towards incentive neutrality, and so that professionals will then do the right thing. And so that's why I am intrigued and hopeful about what's called CPC Plus Track 2. It is comprehensive primary care, in which the fee schedule amounts are reduced, and what we use, again, comprehensive payment or capitation or per person payment or whatever we want to call it, is introduced at a major level to try to balance the incentives, actually. This model is very similar to what Denmark has been doing for 20 years, and they spend a lot of time trying to figure out how do we balance the amount of fee-for-service and the amount of per month payment so that actually the physicians don't have strong incentives to either over-provide or under-provide. And then if you get that right, which isn't easy, then you get to do the right thing for patients, and that's where your investment would come in. And so I think what we now have is a system, a fee schedule-based system that has major incentives to do too much of certain kinds of things and not enough to do other kinds of things. And we need to correct that, but then balance that with a payment so that we're moving towards incentive neutrality.
I just want to follow up and connect that back to the first question. In capitated models, or again, whatever the appropriate term is at the moment, there's also the concern of significant under-provision of care that we tend to think we're going to be able to address through these various measures, and they may, but certainly for people with very significant costs, they may not. So if I'm understanding you correctly, what you're suggesting is, when we asked sort of the engineering question, which was my first question, if we can cut off the tails on both sides of how outlier performance, either excess or far too much stinting on care, that's the primary engineering challenge, and to not then try to heavily engineer the middle and let professionalism play out. Is that a fair way to capture what you said?
I think that is. I would just add one point. I think, using your example of capitation, we now have pretty good measures for primary and secondary prevention measures, and they're very useful. But that doesn't measure one of the real dangers of capitation, is that you don't get referred out of your network. We've got an orthopedist. You don't need to see a hand surgeon. In fact, you're not even told that there's a hand surgeon in the world, because we have an orthopedist who can handle your problem. So my only point is, measures aren't going to do it all. We need some process protections as well, whether that's appeals and grievances or ombuds people who somebody can go to and say, I would actually say we should have ACOs develop referral guidelines, and at a very granular level. Here are the conditions for which we would need to refer somebody outside of our own network. So my only distinction is that we can't do it all with measurement. Measurement is part of the protection, but process protections need to happen as well.
There's also a charter for professionalism for medical organizations. So the same standards that we hold the individual practitioners to on our healthcare teams, we need to hold our medical organizations to as well.
So I'll throw one last question in the mix before opening it up to the room. And again, it's just sort of a sequence of what's already been raised, which is this issue of primary and specialty care, the quite robust collection of measures we have around primary care, the need for much more specificity for specialty care, the opportunities for more episode-based bundles and the like. If we were to gauge, and then, of course, the need to bring these two together, because people's real patients see both. If we were to gauge where we are relative to where we need to be in defining and rewarding value on the primary care side, on the specialty care side, and on the integration of those two in a way that meets the needs of patients, how would you characterize, A to F, 0 to 100, whatever you want to call it? Where are we doing the best and furthest along? Where do we have the biggest gaps?
So I'll start with this one. So those of you who've heard me speak before, I say this a lot. We have both too many and not enough measures. I think we have better measures on probably the primary care side related to prevention, as Bob was saying. Also, some of the population-based measures that may be more relevant for large primary care or multi-specialty practices. If you actually look at the measure set that's available now in MIPS, over 80% are specialty measures. There's this misperception that there's not any. The problem is that most of those measures, which by the way have been developed mostly by specialty societies over the years, probably now that we know more about measurement and what works and what doesn't work in measurement, aren't all the right measures. So I think in particular, the specialty side, that there is a need for better, more outcome and patient-reported outcome-based measures. I would also argue, though, and there's a variety of opinion on this, definitely, that there's a lot of measures out there that actually really should cross specialties, that really all clinicians who see patients probably should be held accountable for, have some responsibility for. And so there, again, some of those are in existence, are in use, but probably not always the right ones. So I don't think we're at an F. We're definitely not at an A. I'd probably put us at a C- or something along those lines.
And I generally agree with what Kate said. Obviously, given some of my earlier comments, I think we're thinking too many, at least from a programmatic point of view. We certainly agree that a lot of them that are created by the specialty societies often don't have a lot of value. But I also wanted to say one other thing about the exchange between you and Bob. I was confused by a lot of it. No, I actually not what you said. Actually, forget that. One thing to keep, this is what I wanted to say, one thing to keep in mind about some of the models that we're talking about. So there's managed care where you have a network, and I thought a lot of your comments applied to that setting. But what was throwing me a bit is some of these other models we're talking about fee-for-service, and so take an accountable care organization. If you don't get that referral, that beneficiary can walk away and go get that referral themselves. And so one of the things that I've been thinking, and I don't know if this is right, but thinking is that, in an MA environment or a managed care environment, you choose, you make an active choice, you're in this network. In the ACO, the most present APM, if you will, you're attributed. And if that APM doesn't do right by you, the beneficiary walks. And so, there's some friction to your hand surgery.
Yeah, no, I understand that, but in the real world, once we get to real risk rather than upside only or risk that's non-nominal but not a lot, I think we are going to have, especially hospital system-based ACOs, the referrals won't be as...
Yeah, I think
patients need to be informed, and they don't even know when they're being given the information. You're right, they have the right to go anywhere they want, but in fact, will we be engaged in shared decision-making processes and robust information so that they know there's even an issue about that? But there's no question that in a very tight network, managed care network, the issue is much greater, but I think that's where we would be moving. To the specific question, I guess my only sort of dissent is that I think there are some important clinical areas where measure gaps are just inevitable, that we're not going to fix them. And the MACRA can say to CMS, go fill the measure gaps, but we are increasingly understanding the problem of misdiagnosis. And I don't know how we are going to be measuring a radiologist's performance in interpreting images from claims data, from self-report. They don't know they've made an error. And I just think we need other approaches as well, again, and not assume that some of the more important things we want to be able to measure and hold people accountable for, we can do through even with robust electronic health records, although I think that could help.
I agree with everything that was said. I think the issue of attribution is a tricky one. When you have a physician or another important part of our healthcare team working in that team, and they are reliant, that patient has an entire system that everything has to align right for them to have a successful outcome. I think the attribution issue is tricky. I think there are a lot of gaps in these measures, and I think it comes down again to time, face-to-face time, having the patients understand why you're not ordering this test, why you're not using this person as to refer them to, and being able to do that shared decision making and understanding what the patient's goals and concerns are.
Okay, we have some time to open it up to all of you. We have microphones, so I want to make sure we capture your comments or thoughts on a microphone. So I see a gentleman here, and if we can get a mic to him, we'll get started.
Joel Coopersmith from Georgetown University. As part of the discussion of administrative burden, which undoubtedly affects quality, how do you create policies that examine this and also examine the unintended general consequences of narrowly focused policies at the same time that you're creating those policies?
Well, I would urge you to actually take a look at our paper that came out a couple of weeks ago on administrative burden. It really gives you a general framework to begin to examine this in a systematic way and drill down from what the administrative burden that's being put on the systems, the individual practitioners, in terms of looking at the framework of the purpose, the intent, the effect, and the solutions, so that you can start to do it at both a macro and a micro level. I think it all starts with a conversation. People want to get to better quality of care. Physicians on the ground want that, but we need to have transparency in why we are affecting this burden, and get to their ideas and the system ideas about how to fix it. I'll give you one quick example. I saw patients yesterday. We went in and checked. We ordered new medications for the patients. We reviewed the medicines for the patients. But unless I clicked the medication reviewed button in the electronic health record, I do not get credit for it. So that's the way that this system is set up, and it just seems that we should be able to have the simple things like that more seamlessly integrated into our workflow and pulled out and extracted.
The one thing I'll just add, I'll tell you sort of some things that we are trying to do to get exactly to your point of understanding the burden and being able to craft policies that don't have sort of additional unintended consequences. We've been holding a number of, we have actually one coming up this Friday in Kansas City, a number of listening sessions with frontline practitioners and practice managers, which is very important. About burden, around quality measurement, about use of EHRs, around documentation for medical review and coverage and that sort of thing. And what I think we've discovered is that it is so important to understand the details of that burden. And also, one of the things we've learned is clinicians will accept some burden. And the story we're getting is not get rid of all our burden. It's make it, we're fine with burden as long as it's something that's meaningful to us, that actually can help us improve care for our patients. Then we're fine doing the clicks, we're fine doing the documentation, we're fine reporting the quality measures as long as it's actually meaningful. But one of the things we've discovered as we've been hearing about the details of where clinicians feel burden is the attribution of that burden is not always in the right place. So understanding the root causes, where CMS has a policy lever and where we don't, I think is going to be really important as well.
Over there.
Hi, Barbara Tomar from the College of Emergency Physicians. This is a terrific discussion, but I think a lot of times when I hear experts talk about this, the rank and file of our respective specialties pretty much don't have a clue. I mean, we represent sort of the failure metric for most of the measures because, it's going to the emergency department. But my question today is, as we move forward in MACRA, and I think most specialties feel that APMs is the way to go in the longer term, and I look at some of the applications from PTAC that Dr. Berenson mentioned, it seems like we have 1,000 flowers blooming for all these new little silos to come up that only deal with one specialty and one aspect of that specialty. And we see ourselves as a part of many specialties because there's always a percentage of people that are going to fall off and end up in the emergency department. But what's the end game? Where do we hope to get with hundreds of APMs, thousands, or where are we heading with this?
So, I want to start with this one. Bob made some reference to this, and I was going to say something at the time, but I thought I'd just let the flow go on. But now I feel like this is implicated again. I think it raises questions about whether you're headed back to fragmentation. Remember, everybody's, we need to move away from fragmented fee-for-service, and some of this measurement and attention that Kate has referred back to, and it's true. You have to measure me at my individual thing that I do for the patient right in front of me, and then I see the 1,000 flowers or whatever was said is also manifestations of that. People coming forward and saying, "This is my model. I'm going to build it around my thing, and then now I want you to do this." Again, I am concerned about Kate's coming heart attack, and part of the reasons, we have physicians here, you'll be okay. I'm not going to be helpful, but other people will. I get concerned at a couple of levels, at just a philosophical signal level. If you're inside a system and, each of these little things are carved out, how do you actually get a consistent set of signals? At an administrability level, how do you decide where, let's just say there's savings, where you begin to allocate those dollars? Do they first go to the ACO that the provider is in, and also the bundle that they're in? And if the patient is cutting across the bundle, I have concerns about how far this goes and whether you kind of end up back with a fragmented system. On the other hand, to the extent that some of these ideas turn into kind of ambient payment and pricing mechanisms, it might be different. But to the extent that you end up with a large system and say 10 or 20 different bundles underneath that, how the incentive structure works among the various providers and at an aggregate level, how someone like Kate decides whether this has been successful and where that dollar lands strikes me as very complicated.
So let me go for that one as well. here's the point I would make, is that everybody is looking to get an AAPM, to get the 5% and to get out from under MIPS. And so now 1,000 flowers are not only blooming, but trying to have dollars attached to it. And a number of the models that are addressing real issues strike me as quite amenable to fixes under the Medicare physician fee schedule. And in fact, I give CMS a fair amount of credit in recent years of pushing the envelope a little bit in new coding for complex chronic care codes and transition codes and extended time periods. And I've got some concerns about the gameability of that, but it's the right direction to be going. So when a number of specialty societies come in with an idea that boils down to it's a specialty medical home. Now, I know some of the primary care groups want to preserve medical home as a specific meaning because it isn't the same as a specialty place, so I would call it something else. I wouldn't call it a medical home. But the point is, an oncologist should be getting paid less for administering drugs and more for doing those other activities that we associate with good care coordination and communication and informed decision making, shared decision making, and responsiveness and 24/7 rather than the procedure or the administration. And so again, it's why I don't think this continuum makes a lot of sense, that we can have much more value with some of these ideas by continuing to evolve the fee schedule. And then I would reserve alternative payment models for real broad approaches and not try to develop a left arm episode or whatever it might be for everything that comes along. I think most of those ideas there can be generic coding placed on them. And again, I would like to test it. Rather than before putting it out in the entire world. The PTAC actually has developed a concept called limited scale testing, which I would have loved to be able to do when I was at CMS, when there's a new idea for coding, to have a relatively small set of practices that tries some of this stuff out and figures out how to get it right. The complex chronic care code was announced in 2015. It was considered too burdensome because of this requirement and that requirement. But CMS only could do this through rulemaking, and so 2 years later they changed the rule when they got sort of general feedback. I think there's probably a better way, or at least I'm not replacing rulemaking, but I think if CMS had opportunities for this kind of limited scale application to see how something actually plays out on a limited scale, it would improve the situation.
Yeah, and I was trying to say, and I agree, that some of this, I think, can be reflected in the ambient payment system.
Can you say that to Mike?
I was just saying that I think you put it better. I made a quick reference to maybe these things make more sense in the ambient payment system, and that's what I'm trying to say. Some of these ideas you reflect in the fee schedule in this particular instance. Yeah. This is a physician panel, I guess. Yeah. And, so you reflect it there as opposed to building a whole model around it.
That's right.
I agree with that.
Well, we're out of time for our first panel. I hope we have achieved what we set out to do, which is to both give a sense of where we are going from a policy perspective, but also the challenges that we're facing and some really interesting approaches to addressing those. We are going to take a 10-minute or so break after this, but please join me in thanking our first panelists. Okay, we're going to go ahead and start our second panel, which is focusing on hospital payment. As I mentioned at the opening, we have some more experience on the hospital side. We have some payment models in place, and there's been a significant amount of analysis of the effects and implications of those payment models, both their overall effects, their effects on care, some of their distributional effects. Much of that analysis, of course, published in Health Affairs, but we'll even admit that some of it has appeared elsewhere. Since we have a bit of a track record, we have also had some time to grapple on a more practical level with some of the topics that arose in the first session this morning. In theory, because we have a smaller number of targets of our payment policy in hospitals than in physicians, some kinds of conversations and types of analyses should be somewhat easier. The complexity, however, of the sector and the variability across participants in the sector is certainly as great, if not greater in some respects, than on the physician side. So for our second panel, you will hear from Bruce Siegel, President and CEO of America's Essential Hospitals, a membership organization representing hospitals committed to caring for the uninsured and vulnerable populations with 275 member organizations. You'll hear from Cynthia Barnard, Vice President for Quality for Northwestern Memorial Health Care, which is an integrated academic health system, and principal at the Academic Medical Center and principal clinical affiliate of the Northwestern University Feinberg School of Medicine. Ashish K, KT Lee, Professor of Health Policy at the Harvard T.H. Chan School of Public Health and Director of the Harvard Global Health Institute. And Jonathan Perlin, President for Clinical Services and Chief Medical Officer of HCA, the Hospital Corporation of America based in Nashville, Tennessee. I'll turn it over first to Bruce.
Thank you, Alan, and thank you for having us all here today and putting these issues front and center. I was told in no uncertain terms by Alan that I have 7 minutes to talk about the future of hospital quality measurement or some such thing. So we'll try to do it in 6 minutes and 30 seconds. And I'm trying to advance this stuff. There we go. Okay, great. So I'm going to talk about, three big challenges and opportunities going forward in this whole area. One is on risk adjustment, why it's important and what's happening. The second on consumer measurement, where I think we're making really a terrible hash of things. And third, I'm going to depart from the Medicare bubble for a minute and talk about Medicaid, which I hope is not too impolite, Alan. Let's talk first of all about risk adjustment. So, we heard from Dr. Moyer before a little bit about, her care for the most vulnerable. And if you walk around her hospital in North Philadelphia at Temple, it is hard to imagine, and the science bears this out, that there's no connection between social risk factors and certain outcomes like hospital readmission. Actually, the evidence is pretty clear. There's been a raging debate about this in our country, especially within, I also say within the Beltway. And I think to some extent we're seeing the pendulum start to swing. We saw it in the 21st Century Cures Bill, where there's at least now explicit contemplation of risk adjustment for social risk factors in the hospital readmissions program. And we're seeing it in a series of reports coming out of the National Academy of Medicine, ASPE, and the like. Just actually in this past week in the proposed IPPS rule, we see the first steps towards this. It's really more about sort of peer grouping hospitals, which is the initial step around their readmissions penalties. But there's clear contemplation in the law and in the rule that we're going to move towards actually risk adjusting the actual quality outcomes eventually. And interestingly, in that rule, you also saw HHS and CMS sort of starting to sort of hint that we're going to think about this in other areas of hospital quality measurement and payment as well. So I think at least that conversation has been joined. Initially we're just looking at payment change, but I would argue we have to really think about also adjusting those quality measures. If we're going to give people really fair comparisons on quality at various facilities, hospital systems across America, then risk adjustment I think has to be part of that equation. It has huge also reputational implications. So moving on, that risk adjustment issue also comes up in the area of consumer measurement. And, we've seen already with the 5-star ratings, which is CMS's, initial take at big picture, big dot consumer measurement for hospitals, sort of the, implications of a lack of risk adjustment. Some of the measures And there are, I think, depending on who you ask, 57 or 64 or some number of measures that are composed into the 5-star rating as a composite, should be risk adjusted and aren't. And so that begins to raise questions about what are we giving consumers to make decisions. The 5-star ratings also has, other issues. You have things like the PSI 90 measure, which is itself a composite of things which some might argue may not be clinically significant, rolled into that measure, and then that's rolled into the 5 stars. You have a composite of a composite. Really complicated, and you wonder how all this stuff is mixed and matched and who kind of decided how to do this. I'd say further, though, in the whole area of consumer measurement, and perhaps the bigger challenge is this, well, I'll call the consumer cacophony. We just have so many ways in which we're putting out different information about hospitals in America, and I don't know that we really are serving consumers well by doing this. And I don't know how many of these things are really more about somebody's business model as a measurement entity or entity getting into measurement, and how much of it is really about providing really good, actionable information for consumers to use. There is just so much out there. It's different. And even, I'm only showing some of it. I spend every week visiting a hospital somewhere in the country. And every time I go to a hospital, not only can they tout how great they are on some of these measures, at least one, in addition to this, they can tout, well, we have the first accredited X center accredited by Y, and we have the first accredited this center in our state. You put it all together, what are consumers really to make of this? I think not much, and we need to really take a step back and think about how we're doing this, and whether we're really, serving people or just giving them what I call spurious precision. Finally, I just want to spend a couple of minutes on Medicaid, which I know is not the main thrust, but I think it's important to spend a second on it. We just ended a major debate around coverage in this country with the American Health Care Act. I shouldn't say we ended it, we ended the first phase of it. And one of the things we discovered, who knew, there are 74 million people on Medicaid. Amazing. And so I think we have a huge challenge. How are we going to measure quality in hospitals or anywhere else for that population? Most of what we've done in quality is built on a Medicare chassis, and that makes complete sense. But now it's got to be adapted or recreated for a Medicaid chassis. Do we have the measures that we need to manage populations who have different challenges, behavioral health, addictions, psychiatry, on and on and on? And then also, do we have the ability to monitor what's going to happen in this great experiment? Because if you look at the indications from HHS and CMS, and we knew this before, there's going to be, I think, a really active area of seeking waivers from states. Things like higher cost sharing, drug testing, et cetera, et cetera, et cetera. I know Wisconsin's coming in with one as of yesterday that looks like this. Well, what are the access barriers we're going to create or not create? How are we going to facilitate access? What are the implications of HSAs for Medicaid patients or patients on the exchanges? That we've got to measure also, and I'm not sure we're ready to do that. And that's going to be the third biggest challenge. And with that, I'll give Alan back 9 seconds. Alan?
Good morning. Thank you for the opportunity to be here.
A little closer.
Yep. Alan Weil doesn't know this, but he's been my hero for about a year, ever since he published this line in the theme issue of Health Affairs a year ago, saying what we have all long believed, which is, if you look at our system, it clearly was not designed with patients in mind. Our aim ought to be to think about value from the patient's perspective. And the first point I want to make about that is, as many measures as we have, water everywhere, but not a drop to drink, we're lacking measures in some important domains to our patients. For example, earlier this morning, patient-reported outcomes were mentioned. What is the actual outcome of the patient's care? We can measure negative outcomes, readmissions, infections, complications, and death, we don't measure successful outcomes in any of our accountability programs. It's time for us to turn our attention to this. Other measures really important to our patients, also mentioned earlier, were diagnostic accuracy and indeed promptness. We need to think about what are the outcomes more broadly. That will take time and development, but that is what value really is. The other problem is the other half of the equation, which is cost. Cost to whom? Cost to the payer is one thing. Cost to the patient is something completely different, and it may even be unique to each patient based on that person's personal mix of circumstances. And then cost to the provider, which we, in some cases, don't even have good cost accounting. So we have a problem with value outcomes, and we have a problem with cost. I do want to touch briefly on 4 problems with measurement, and later this morning we'll talk more about measurement, a little bit about implementation, and some solutions to these problems, none of which are easy. Work we've done highlights the first problem, which is the look more, find more problem. For both patient safety indicators and infections, which dominate our incentives and penalties, we have a serious problem in which better resourced, more dedicated organizations, more sophisticated places are looking more and finding more of these things. And as a patient, you want us to do that. But when the metrics are built around penalties for these things, the contradictory incentives should be very clear. Even when all the processes are implemented properly, looking for more blood clots, as in this particular example, will find them. And the same is true for infections. When you add up those phenomena, what you see is the hospital-acquired conditions penalty, which is constructed of those 2 components, disproportionately penalizes just the organizations you might think are investing the most in quality. The urban hospitals, the large hospitals, and the teaching hospitals. This does not pass a common sense test, and it's a reflection of those underlying measures. The concept that Bruce mentioned of composites that themselves are questionable begins to demonstrate the problem. The New York Times picked this up in a nice piece by Jordan Rao about a year ago, in which he came and talked to a bunch of our folks about what we're seeing every day. We have not stopped being more careful in order to avoid the penalty, but you can see the problem. We've already addressed the composite problem a little bit this morning, and I won't spend a lot of time on it, only to mention that if the PSIs, the patient safety indicators themselves, driven by billing coding data, are fraught with difficulties, then rolling them up into a composite will simply compound that problem. And we did publish a paper in which we highlighted a number of the concerns that we saw. I give CMS a ton of credit and the team at Yale for trying to improve this metric. The new PSI 90 will, we think, maybe be a little bit better, but it is fundamentally fraught with the same problems. There is a look more, find more problem with patient safety indicators, and the new PSI 90 is still driven by only 4 of the PSIs. To the extent they are problematic, the overall will also be problematic. Another kind of composite is the star rating, which Bruce mentioned. And what this complicated picture tries to show you is the more measures you have available on the y-axis, the worse your star rating. There is something wrong with that picture. Therefore, what you see is that the blue are the large teaching hospitals, the yellow are the teaching hospitals. They all are clustering off to the left in the 1 and 2 star ratings and 3s. What do you see in the far right in the 5-star ratings? Mainly the specialty hospitals, which have very few ratings. There's the design of the composite is driving the outcome. We all want composites. We want better ways to communicate quality to our consumers. As Bruce pointed out, this doesn't seem yet to be quite where we want it to be. The third problem is meaningfulness of measures, and readmission is a great example. Is it appropriate for a patient who presents to us to be readmitted? We have no measure of an appropriate readmission, but let's assume for the moment that every readmission was clinically appropriate at the time. Then your question is, could we have prevented it? Were there interventions we might have implemented that would have kept that patient safe in another setting? Have we accounted for socio-demographic status, which again Bruce commented on? Factors that prevented the patient from getting the medication, the primary and secondary care, materials in the patient's own language that would have kept them safe in another setting. What about timeframes? Research that you may have all seen begins to show that readmissions within that first week appear clinically to be more preventable than readmissions in that 8 through 30 days. That seems like great common sense, but yet why are we still focused on 30-day readmissions? The further away you get from the index admission, the less preventable we seem to be. And then there's the problem of unintended consequences of readmission measurement. There is evidence that readmissions and mortality may be inversely related in some settings, in some conditions. If that's true, we should be very humble about this. We should be careful about how we incentivize. And a team at Michigan did an interesting thought experiment in which they said, what if we incentivized readmissions and mortality to an equal degree, instead of, as we do today, penalizing readmissions 10 times more than mortality? That doesn't pass a common sense test. And what they found was when they re-engineered the numbers, there were dramatic changes in penalties. This should give us pause and realize that to the extent that measures are not meaningful and reliable, we better dial down the incentives a little bit. Finally, let me talk about integrity of data, because this is terribly important if we're going to create accountability. About 18 months ago, we got a rather stunning email from CMS and the CDC, which said, would you please be more honest in the way you report infections to us? What they said was, we're seeing two problems. One problem they reported is that clinicians were behaving differently to avoid identifying infections and then reporting them. This should concern us if this is true. What they also saw, and this component I personally believe is very, very true, and there's ample evidence, is that organizations are identifying infections using the CDC criteria, but then after a clinical adjudication process are deciding not to report them. For good clinical reasons, they are concluding this infection was actually present on admission. This infection was actually secondary to some other site. I'm sure they're right. I'm sure they're doing this with clinical integrity, but they're not following the letter of the definitions. So two problems. One is we want to work with CDC to improve those definitions, and although they have a very long lead time, they're certainly willing to look at that. The other problem, though, is let's be candid that the database we've been developing of infection data may be deeply flawed if there has been this kind of clinical adjudication before people are submitting their infection data. This follows up on 5 years ago, a group of different organizations warned that this problem was percolating and advised action to prevent it. And there really has not been the traction that we need to see for good quality control for quality data. I won't speak about consumer confusion because Bruce did a nice job, only to point out that Health Affairs published a nice paper on this a couple of years ago, demonstrating the lack of coherence among consumer reports of quality. We've touched on almost all of these unintended consequences, and I won't go over them, only to say maybe we'll discuss them a little bit later. But there are a number of problems with our current system, and I am certainly not an advocate for fee-for-service and lack of quality measurement and accountability, but we have a tremendous opportunity to improve the system. We want to use this opportunity to make it better and not simply throw new problems on top of old ones. An example of a solution will be EMR-driven quality metrics, as was alluded to earlier. A great EMR that supports good care and spins off quality measures, that's the holy grail. That will avoid gaming, and that will bring us to truly better care, both in the moment of providing that care and in measurement and improvement and accountability over time. So, in conclusion, what we want to do is we want more meaningful measures on domains that matter to patients, drive them out of the EMR, speed our improvement cycles, make those measures better, quicker. We will focus our improvement capacity as an industry on these important measures once they're identified, verify the data, maintain that professionalism, keep the provider and patient at the center of how we define quality, and be a little bit cautious, like the old map makers who put monsters in the oceans. We got to get our feet wet in these new measures, but let's do so carefully and let's make things better, not worse. Thank you.
So good morning, everybody. I don't have slides, and it's actually hard to follow Bruce and Cindy because they made a lot of the points that I wanted to make. But I'm going to take a few minutes and cover just a little bit of ground about how I think we're doing on the hospital side. And I want to start off with a very quick thought experiment, which is imagine one of your family members got acutely ill today and was hospitalized. Could be your child, could be your spouse, could be your parent. What would you care about? What would matter to you? What would be on the top of your list as a way to ensuring or measuring that they got good care? Well, if you ask most people, they start off with death. Like, all else held equal, I'd rather they not die. Right? And it turns out that that's really important. Like, everything else feels a little secondary to it. Second is, and again, I'm not giving the rest in order because some people will feel a little differently about the second versus third, but I think most people start off with death as the big one. But then the stuff that I hear when I do this in audiences not like this one, not full of experts, but lay audiences, consumers, is people talk about not developing a complication, not developing an infection. Coming out with reasonably good functional status. I mean, they don't use those words, but you get the notion. They're back on their feet. They're able to get back to work. They're able to get back to play, whatever was important. That they're not having pain when they're out, when they're back at home, and that they were treated with dignity and respect along the way. Right? If you imagine a family member who survived, didn't have a complication, had good functional recovery, wasn't in pain, and was treated with dignity and respect, I think we'd all say, that was terrific, right? That was terrific. They weren't readmitted, okay? I think that's in there, but it rarely rises to the level of being 10 times more important than death. But it's on the list. But I think the big ones are death, complications, disability, experience. The good news here is we're measuring a bunch of that stuff. Right? I didn't just give you a list that no one's thought of or we don't have any measures for. We actually have a measure for mortality. Now, it turns out the way we measure mortality, about 2% of hospitals get classified as poor outliers, and everybody basically gets a check. And we can come back to the measurement approach. But we measure mortality. We're sort of measuring complications. I would argue that the complication measures all have lots of problems. When they come out of administrative data, they have huge problems. Even out of the CDC data, as Cindy said, they're not perfect. I think there's progress there. We're measuring experience, actually, I would argue, pretty well. I mean, the HCAHPS measures are really good, well validated, well developed. Functional status, how people are doing at 3 months, how people are doing at 6 months, we're really not doing that. Not in any meaningful way. And we've been, I've been around giving talks on this topic for a while, and most of the times I hear it's about 6 months away. And the last time I heard that was first time I heard that was about 5 years ago, and about 6 months ago I heard that was about 6 months away. And the problem is, it's hard. Patient-reported outcomes is much harder to measure than mortality. Because mortality, you got the claims data already in-house. You just figure out whether they lived or died at 30 days. For patient-reported outcomes, you actually have to go out and collect the data. So some of this is hard, but I want to start off with some good news, which is I think on the stuff that matters, we've got some of those in-house. Now, I want to shift a bit from measurement to the incentive stuff that we have. And I want to ask a very basic question, which is, what does the empirical evidence tell us about whether the current value-based payment models that we have for hospitals, VBP, Hospital Readmission Reduction Program, the HAC penalty program, what does it tell us about whether those things are making a difference on the stuff patients care about? Remember the stuff patient cares about, right? Death, disability, functional status, experience. I think the evidence is mostly depressing. And I say that from somebody who's been a big fan of pay for performance for a very long time. Right? I have not been a critic. I believe in pay for performance. And yet, I think the evidence is VBP has had no impact on mortality. And if you're going to be just a scientist and not actually worry about implications of what I'm about to say, you would say mortality rates were falling at a much more brisk pace before pay for performance kicked in, and they've actually, the declines have slowed considerably since VBP. At least it's good evidence that VBP hasn't made things any better. VBP has had no impact on patient experience. And the other stuff, the process measures, they were already pretty topped out, and it's not really clear that it's made much of a difference there either. The hospital readmission reduction program is more interesting because what is clear is that as soon as President Obama signed the bill, the Affordable Care Act with HRRP in it, readmission rates started falling. About a year and a half before the penalties actually kicked in. And once the penalties kicked in, the readmission rate declines have actually slowed and plateaued. So there's something funny there, but the general thinking is hospitals knew it was coming and responded. But what we have seen is a decline initially and then a leveling out, at least through 2014, early 2015. And the hack penalty program, this is the one that has the 1% penalty for people doing in the worst quartile. I would say on this one, it's really unclear what has happened. There have been 2 reports by AHRQ that suggest big drops in hospital-acquired conditions. When you dig underneath the hood, and it's actually pretty hard because this stuff hasn't really been peer-reviewed and hasn't really gone through any substantial scrutiny, but when you dig underneath the hood, it's actually hard to figure out what has gotten better, what has gotten better because of the hack penalty program. Some of it is like central line infections have fallen. Well, terrific, but they started falling in 2007 because Peter Pronovost and the whole checklist stuff got going well before the hack penalty program. So you can't attribute it there. So there's a lot of confusion, but I would argue that so far this has not been a home run. So how do we move forward? And how do we do this in a way? Again, I'm the guy who believes in pay for performance, and yet here we are feeling like we're not quite getting this right. One, I think, certainly is some effort to do simplification of measures. We have, and everybody says this, but I feel obligated to say it. We have too many measures, they measure too many things that are not important, and we don't have enough measures of stuff that is important, right? A substantial simplification focusing on 3, 4, 5 things that I argued you would care about if it was your family member. That needs to be in the bucket of what needs to be incentivized. Second is, as I said, addition of important stuff. I do think patient-reported outcomes is critical. And I will tell you as a practicing clinician, as a hospitalist, how I practice medicine in the hospital, especially to older people, has a profound effect on how long it takes for them to recover, to get back on their feet. So I think that's really critically important. The third, and this is a place where I unfortunately missed the first panel, Bob Berenson and I have, I think respectfully, disagreed on this. Bob occasionally likes to say pay for performance is a concept whose time has passed. I actually am still a believer and think we should try much more substantial incentives on pay for performance. Right now we have tiny little incentives spread out across dozens and dozens and dozens of measures. If we put real incentives on the table, 5, 10%, on a small number of measures, I think at least there's a chance that we can make a difference. And then last but not least is risk adjustment and socioeconomic status. If we're going to push towards outcomes, if we're going to push towards things that have a profound, are profoundly influenced by who the patient is, what the context is in which they live, this fight that we've had over the readmission reduction program worries me a bit because there's been a lot of, I think, obfuscation and mischaracterization. No one's saying we should have a lower standard for people who are poor or people who are minorities. What we're saying is you shouldn't penalize hospitals because they have more poor patients. Right? There is a distinction between those two concepts, and we have not gotten that distinction down. We've got to, and I do think the 21st Century Cures Act is a step forward. We've just got to understand that if we're going to use outcomes to guide us, we have to take socioeconomic status and risk really much more into account. So last point on this is that this is much like quality improvement. Right? This is policy improvement, which is we tried a bunch of stuff in 2010. They were all pretty reasonable things to try. We put in a bunch of quality measures. We have discovered over the last 6, 7 years that a lot of it isn't working very well. This is not an indictment of the people who did that. They were doing the best they could. But we've got to go back and improve the measures, we've got to improve the incentive program, and we've got to try again, because the alternative is to throw up our hands and decide we're going to do nothing at all, and I don't think that's something that any of us want. Thank you.
Well, good morning. And thank you very much, Ellen Health Affairs, for putting on a terrific conference, to the Federation of American Hospitals and Chip Kahn for your leadership and support, along with the Commonwealth Fund. I want to sort of build off of my colleagues here this morning. Bruce spoke about the cacophony in the measurement world and some of the perverse findings that are generated by measures that may be at odds with certain realities. She spoke very meaningfully to what's important to patients and their families and societally. And Cindy spoke eloquently to the burden of measurement. In that, a theme that emerged from the prior panel was this conundrum between being able to focus on the big picture, moving those things that are really important, and the granularity necessary to manage data effectively. And I think that really calls for a new paradigm, and that's really what I want to speak about this morning. In fact, resolving this conundrum brings me actually to optimism based on experience in a large health system and with the privilege of having served as the chair of the Health IT Standards Committee in the implementation of meaningful use. It's pretty clear that too many of our measures are currently based on this world. Oops, well, not that world. Come back. And a world of paper. That is a master patient index on the bottom right. And obviously not a great source for longitudinal outcomes looking at population health or patient-reported measures specifically. In fact, we have this opportunity in a post-meaningful use environment, which is fundamentally this, is every patient encounter now spins off what the data wonks call a data exhaust. And that exhaust, if we capture it, really can be used to be turned into knowledge and reapplied at the point of care, hopefully wisely, in improving, personalizing, and meeting the very important needs that Ashish spoke to, or actually applied back into the health system in terms of system improvement. This fundamentally is the underpinning of a learning health system, one that uses the product, information product of patient care in learning and continuous improvement. I want to show you an example of this paradigm that I think speaks to resolving this conundrum between big picture and granular data. We continue to have an epidemic of hospital-acquired infections in the United States. About 1 in 20 hospitalized patients acquire an infection. About 80,000 die. Just to put that in perspective, that 80,000 would be the number 6 cause of recorded death in the United States and more than the total of breast cancer, car accidents, and HIV combined. And a large part of that horrible toll is attributable to forms of staph, including methicillin-resistant Staph aureus, or MRSA. And beyond the ultimate cost that patients pay, there's a financial cost approaching $40 billion a year. So we had implemented across my health system a mechanism to reduce MRSA, and we were actually operating about a third better than expected by screening patients for methicillin-resistant Staph aureus, and if they were MRSA positive, putting them in isolation. This data were presented, and some colleagues from CDC and Harvard came up and said, well, that's nice, but how do you know that's best? Could you use the system to actually conduct an experiment comparing that as base case against screen isolation, an antiseptic sponge bath, a nasal antibiotic, or just sponge bath and antibiotic for all, and see what happens? The hospitals were randomized, not by individual patient, but by hospital. The study was pragmatic research done in the course of routine care, and it built on this framework of meaningful use. It had, we had standardized data by virtue of what was implemented in 2009, 2010. And so in that next 18-month period, 43 hospitals were grouped into 3 groups, screen, isolate, decolonize, decolonize all. And you see over that period, there were roughly 75,000 patients accrued and across 80 ICUs. Well, the nominal headline in the New England Journal was that this approach, on top of all known best practices, reduced potentially life-threatening hospital-acquired infections by nearly half, 44%. Number needed to treat for every 99 decolonized, 1 life-threatening infection avoided. And it was testament to many things, and that's an important headline, but I don't think it was the singularly important headline. I think that's here as well. First, it didn't take one hospital 64 years to acquire the data. If you do the math, it took 43 hospitals 18 months. Second, it didn't take the proverbial 17 years to translate. It took 2 quarters, and we can talk about why that is. And then third, there was also a return in financial terms beyond the return in human terms, a dividend of $170,000 for every 1,000 patients decolonized, calculated by colleagues at Kaiser Permanente. It brought the expected infection rate down, not the 44% that the study predicted, 42%, pretty close, but down to an overall expected infection rate that was about 4/10 of what would be predicted. So let me close with this concept. We are in a post-meaningful use world. We're in an environment where 98% of hospitals are computerized. We're in an environment where 95% of physician practices are computerized. We are creating the data. The question is, are we learning? Can we use this to create the holy grail that Cindy spoke of in terms of resolving this conundrum between moving big picture issues like hospital-acquired infections and managing with the granularity that gives providers the ability to do important work? We think the answer is yes. That was just a start. Some of our current work is work that's in the general medical and surgical unit. We were shooting for 300,000 patients last year. We got 600,000 patients across 53 hospitals. And because there's always a theoretical risk of resistance to a nasal antibiotic, we're going for an antiseptic. And because the rates are so low, we need 140 hospitals, 1 million patients, 12 months. Well, at that scale, I think we really are providing a metaphor for what we could do more effectively in terms of using that data exhaust for clinical performance measurement. So let me close with a bit of a replay of last year, modified a little bit, which are some principles that I think are particularly apropos in this new post-paper world. That good measurement should be about patient care, about improving population health, or improving value. That provider behavior affects outcome. Something alluded to in Ashish's comments. The timely reporting supports really making this a virtuous cycle, a closed loop of learning and improvement. That there are rational financial incentives, and that, to Ashish's point, may mean that they need to be compelling enough to move the needle. That there are strong evidence for the underlying recommendations. Measures are, if you will, the interrogative of a recommendation. That there's strong evidence for the measure itself, including in the mode of administration, because something works on paper doesn't mean it's going to work or be valid or be reliable or interpretable in the electronic environment. That measures avoid unintended consequences, pain management, and HCAHPS as an example. That it reveals meaningful differences for evaluation, especially. The methods for risk adjustment, in particular, are open, transparent, knowable, so that providers who are accountable can actually manage, learn, improve, close that cycle. The measures are part of a coherent framework for improving value. Bruce spoke eloquently that there are entire segments of the population that have been systematically neglected in our measurement. We need an overriding architecture. Vital Measures is an example. Some of the great work the Quality Forum is doing, National Quality Forum is doing, speaks to that. But we really need to think about how we move population health as well as individual care. And just as a corollary, population health isn't necessarily just the aggregate of individual care. And then finally, that measures are fit for purpose, be that purpose learning, improvement, or value, and that we can achieve through mechanisms like electronic records, reasonable administrative simplicity, that the benefit of the measurement exceeds the cost of implementing the measure, and the measure focuses us on the purpose of measurement, the learning, the improvement, the value, rather than the reporting exercise. So I would offer you this. We bought the car of meaningful use. It's time to go drive it. And it gives me a great deal of optimism about the future. Thank you very much.
Well, I can already say I am pleased with how the flow of the panel went in bringing up these issues and giving us a status check on where we are, but also some thinking about the future. So I want to come back to Bruce, the only panelist who did adhere to my 7-minute request. So I'll give you an extra minute in your response. I want to go to John's vision and sense of a better platform, which is a very positive one, and now replay the concerns you raised, Bruce, and Cindy, you as well, Cynthia, you as well, and ask what's left? What does that? What issues remain even with the better platform? What is the work still to be done to address the concerns you raised, even if we have richer, faster, more unified data coming out of a beautifully integrated set of electronic health records at the hospital level.
So I'll start with that, and I think the framework that Jonathan laid out is wonderful. It doesn't necessarily tell us how to translate this, say, to the consumer, but I still think it's a wonderful framework, and I think the work that he's been able to do and his colleagues using electronic health records and a learning health system is something we all should need to be modeling and looking at, because this is stuff that couldn't have been done 10 years ago and is frankly a product of good government policy, and we should acknowledge that and celebrate that. John and I both are on the NQF National Quality Forum board, for full disclosure, and so I'll make this comment with that. I think the problem we have, and I thought we saw in the last panel, is that we are all entitled to our own opinions, but we're not entitled to our own measures. And after what we've seen with MACRA, what we heard about this morning, and what I think will be these very powerful centrifugal forces that will attempt to fragment the measurement enterprise in the years ahead, are sobering at best. And I think if we head towards a future where every specialty has its own measures, rather than patients having measures, all this good work will have been for naught, because the confusion I referenced earlier will just get worse, and everyone will look good on some measure.
Any other reactions to the vision?
So I think this is a tremendous vision to improve the body of measures we have that are contained within the four walls of the record. It can tell us a lot more and automate and save money and time and burden in gathering information on the clinical encounters. What it doesn't tell us is what's outside the four walls of the record, and we need, over time, through learning cycles, to expand the frame of reference. And again, the patients, the sociodemographic issues is a great example of this. What is in the record? Measuring dual eligibles, which is one of the key methods of thinking about this, isn't enough to tell us what challenges this patient is really facing in managing his or her own health. The point made earlier this morning that everyone on Medicare has a chronic condition was funny and true. What it doesn't always tell us is everything else going on in this patient's health and life. So that's one problem, is it only has what it has. And we need to do improvement cycles to ensure that it has more. The other problem it doesn't tell us is about patient selection. Who isn't getting into our system at all? Who has not had a visit during a period of time? Who has not had an encounter? Who is or is not receiving potentially needed care? And then how does the consumer engage with this? I cannot forget a family that confronted us with a belief that one reason the physicians were unwilling to discontinue life support was because this patient was within 2 weeks of completing a year after transplant, and this very sophisticated family knew that mortality a year within transplant is a quality metric for which we could be penalized. We were able to work through that with this family, but we have to remember we're working in a context of taking care of people. We're accountable to them before we're accountable to payers and each other. And we have to come up with measures that work for everybody and are nuanced and sensitive to those concerns. And finally, the lack of measures of appropriate care in general. Again, a learning system can over time address this. But how do we know, the comment was made earlier this morning, that because you're in the bundle for joint replacement, you were genuinely appropriate for that joint replacement, and that the decision-making around that brought you into the bundle in an appropriate way.
So I want to say a couple of things about where I see some things going on this. One is I love Jonathan's vision, and I think it is one that is far more realistic and actually goes even further than it would have been 5 years ago. So I think it's worth remembering, and John sort of alluded to this, but it's worth remembering. In 2009, about 9% of American hospitals had an electronic health record. In 2015, that number is probably a little north of 80%. Right? It is a phenomenal set of activities, events that have happened over the last 6, 7 years, really because of high tech and the Recovery Act that financed this. So that's one piece of good news. Now, we all have problems with the way meaningful use is done, and doctors are unhappy, and we get that, and no one thinks this has been seamless, and no one thinks that we're where we want to be. But we have managed to digitize the American healthcare system, and that's pretty impressive. The second thing that has happened in the last couple of years has been something else that has been promised for a long time, but I think actually has shown up for prime time, and that's machine learning and artificial intelligence. It's been right around the corner for 20 years, but now it's actually here. And that has really happened in the last 2-3 years. Put those phenomena together, and I think our ability to do quality measures in 10 years, and I wouldn't have said this a few years ago, because in general I'm pretty skeptical of the pie in the sky. We're just around the corner from nirvana. I think it's all going to look very different. And the question is, of course, how do we manage it, and what's the current, and how's the current infrastructure and approach to measurement going to handle it? One other theme that I want to just put in is that private sector, and I don't mean private hospitals or private insurance companies, I mean like direct-to-consumer companies, the number of them that are growing, that have incredible amounts of data, that they are very interested in essentially coming up with quality measures and sharing it with consumers. They're much better at marketing to consumers than we are. So companies I think of, and just in interest of full disclosure, I'm on the scientific advisory board of a company called Amino Health. They have data on about 200 million claims data right now, but working on electronic health record data. And the idea is they're going to develop their own quality measures. Are they going to be NQF certified? No. But they're much better at dealing with consumers than I ever will be, or most healthcare organizations will be. So I think there is an external threat coming to the quality enterprise, which is organizations, companies with lots of resources and lots of data creating their own quality measures. That will create more cacophony, but it's actually an interesting pressure on the system to get better or become increasingly irrelevant.
So, Ellen, good theater requires a rebuttal, and I'm not going to rebut. I'm actually going to agree with my colleagues, but really emphasize the how, because I think these points are so important. The point's been made that the patient's life doesn't begin and end with the four walls of the clinical encounter. When I had the privilege of chairing the standards committee, to me the vision of success wasn't that one legacy system could speak to another legacy system. It's that they had open interfaces, so that entrepreneurial environment that Ashish just spoke about would allow those data to come in. When I had the privilege of leading the VA health system, I remember I had patients who had digital scales at home. Today, I'd arm them. I don't want to name a particular device, but you can name your favorite device that would track their activity. That way I'd know if their heart failure was improving or deteriorating. And to me, the vision of the future is one, those open APIs, the programming interfaces, the ability to have that consumer data be a coherent part of a patient's health record, not just a medical record. So I think that's really the future, doable and very exciting. We need to create those handholds. The second is that I think the role of some of the legacy AHRs is going to change. They're going to be the intel inside. It's a broader context around. We could not have, people always ask the question, how did you do that work within the confines of the electronic health record? We didn't do it within the confines. We did it through. The American College of Surgeons, as an example, are using the data that are output from electronic health records into a separate base. And that's a base that can contain knowledge and can help to measure. Third, we need more good measures. I'll agree categorically with that. And, we need identical measures. Think about it. Harmonization is a term of art. When you go out and buy tires for your car, which have a particular measurement, you don't go to the store and say, I'd like them to be pretty close. You don't want to be going down the highway with pretty close tires. You want identical. You want the size that's specified. And what are the features of not having identical measures is that we need important measures, we need good measures, we need measures that move the agenda. But absent measures that are identical, what we do is we distract on different permutations of the same rather than the focus on actually moving something tremendously important. And finally, I just make this last point. Really excited about what Ashish just said about the natural language processing. As excited as I get about the 20 to 30% of the health record that fueled the study I showed you, 20 to 30% of the health record is structured. That means the majority, 70, 80% is text. And machine learning now is actually being used for quality assessment. We did a study that we published at the American Society of Clinical Oncology that demonstrated that to the point that Bob Berenson made earlier about the concern of misdiagnosis, that would overread X-rays, or I'm sorry, CT scans, to identify incidental findings. My favorite cousin died because he had no arthritis or shoulder injury. Unfortunately, dense nodularity that requires follow-up was not attended to. When it finally became the signal issue, it was too late. That was really the point of the National Academy of Medicine's last publication on improving diagnosis. This is really the opportunity. And again, while that may seem like science fiction, we actually have production level activity in this, and perhaps later be happy to talk about that.
Okay, so I want to ask a question from a health affairs lens, which is we're a policy-oriented journal. There are a lot of technical and conceptual ideas being floated around, but policy change is incremental. We have what we have in federal policy, both with respect to high tech, but more directly on this panel with the various payment methods in the hospital arena for Medicare. Incrementally, where would you put your focus on the change that you think is most important to guide the evolution of our hospital value-based payment and enterprise in the right direction? Bruce.
That's a very simple question. So I would emphasize moving us towards systems, and I think some of the APMs do this, which integrate, the caregiving facility and the health professional in some fashion. I think that we, because of payment systems and politics, we have built sort of these different architectures, parallel but different, in hospitals versus now in the physician world of MACRA. And unless we bring those together, it flies in the face of the reality of how healthcare is provided, which is those two being together. You asked a question about how I pick a hospital. Well, usually you don't pick a hospital, usually you pick a doctor, who then picks your hospital. So that's really more the handoff for most people in America, not all, but for most still, who have some sort of either private coverage or Medicare. So understanding that interplay and building systems that reflect that rather than have this sort of to some degree artificial division, I think is the greatest challenge going forward.
Great. Who else wants to? Single policy change move us in the right direction.
Can I throw out a really bad idea?
You're on the record, so you own it. You can throw whatever you want out.
So, like everybody loves patient-centered care. We all believe in patient-centered care. How about this, which is 10% of Medicare payments. We ask the patient 30 days after discharge to decide how much of that goes to the hospital versus goes back to Medicare. So I don't get to keep it, but that 10% is a meaningful amount. I'm not sure my friends in the hospital industry are going to like this idea, so I said it's a bad idea. But it would have a very powerful effect on getting hospitals to focus on what patients care about. Because if 30 days later they're dead, their family member is unlikely to want to give that 10% to the hospital. If they've had a horrible experience in the hospital, they're unlikely to do it. And you and I don't need to figure out what patients want or what they care about. They get to figure it out. Do I have any realistic belief that that's going to happen? No. That's why I said it's a terrible idea. But I'm not convinced that sort of these incremental changes are going to make a big difference. I think we should keep trying. Better measures, better incentives. But it may actually be time for a little bit of bold thinking as well.
Good. That's great. Any other takers, or I'll...
I was just thinking about Ashish's proposal, and
what do you think, Don?
I think we can learn a lot from the airlines. In all seriousness, I think we've spoken about measures that matter. When you think about our deficiencies, it's really systemness, it's coherence, it's achieving good outcomes. I think there's a lot of power in the transparency itself, but I think it gets back to identicality of measures that matters, focused areas. You can't focus on everything simultaneously and hope for that. I would encourage policy and this is obviously going to follow what I spoke about, that encourages more use of the clinical data that we've already created as a basis for understanding. I think that's important for two reasons. Not only for the reasons I mentioned, do I think it simplifies, improves, and accelerates the measure proposition, but it also can help validate or invalidate some of the inferences we take from administrative data. Our system, along with a few hundred other hospitals, about 400 hospitals total, are working with the CDC to look at the relationship between sepsis coding administratively and the clinical features of sepsis. And while I'm not ready to tell you what the answer is, let me just allude to the fact that the hypothesis is not far off base, that there may be some separation there. And the problem, I just can't get ahead of the publication on this or anything in that regard, but I think you hear me saying that there's not absolute symmetry, and I think the gold standard is really in the actual clinical data as an example. So we have this incredible resource. I mean, it's just a mine for discovery, for improvement, and it has the capacity to allow the actual practitioners the granularity that's necessary, as well as the ability to scale. And for those reasons, I think that's an important policy opportunity.
Only to add one other thought, which I completely agree, and that is, in the interim, while we're improving our measures and drawing them from the EMR, I think we need to be a little bit humble about where we throw the incentives. I am worried about incentivizing the wrong things too powerfully, and we want to take incremental steps. 10% is worrisome to the extent that the measures are not great. If it's all 10% around patient preference, we can work with that. I'm not saying I like it, but at least we'd understand it, and it's something we could manage to. Measuring the way we do today with the 60 or however many measures we're dealing with in the star rating and throwing big incentives at them is not producing a coherent, to John's point, a coherent focus on making a few things a lot better, and we can do better than that.
I'm sorry I ran out the clock, but you guys had such rich presentations and such expansive and thoughtful responses to my questions. I'm going to have to call this panel over without getting audience participation, but I think it was great to have the conversation that we had. Please join me in thanking our panelists. Okay, as we transition here, issues of measurement have come up throughout the morning, and it's not surprising, and it's a good thing that it did. What's more complicated is to actually go deeper into some of these issues, and it's a nice opportunity that we have with our third panel to do that. And so, there we go. You will be hearing from Chip Kahn, President and CEO of the Federation of American Hospitals, the advocacy organization for investor-owned hospitals, where he's been since 2001. Peggy O'Kane, the founder and president of NCQA, the National Committee for Quality Assurance, a private 501c3 nonprofit organization dedicated to improving healthcare quality. You'll hear from Niteesh Choudhry, an internist and health services researcher at Harvard Medical School and founding executive director of the Center for Healthcare Delivery Sciences. And you'll hear from Hwang, director of the Center for Consumer Engagement in Health Innovation at Community Catalyst, a consumer organization in Massachusetts. I will turn over first to Chip.
Well, good morning, and thank you, Alan. And I want to express my deep appreciation to you and to Health Affairs and to the Commonwealth Foundation for joining with the Federation to sponsor this really great dialogue this morning on value-based purchasing. Today, I want to address aspects of quality measurement and pose two questions we should consider in this panel. And we've heard a lot about these questions, actually, in the previous panels. First, are we focusing sufficiently on measures that matter? And second, if we can get the measurement right, can we adopt a platform that deploys measures across healthcare settings best to inform patients and accountability while reducing the current redundancies, inefficiencies, and frankly, make work in our assessment efforts. From my viewpoint, the answer to the first question is not enough. We do have a few measures that matter, such as those resulting in the reduction of elective deliveries before 39 weeks, or even the readmissions measures, as flawed as they are, have brought attention on an area where we have achieved great improvement. But much mandated measurement still seems more like check-the-box exercises rather than pathways to quality improvement. On the second question, we clearly lack a process that ensures consistent measurement across patient settings and value-based purchasing programs. Instead, we have balkanized quality measurement and reporting processes where clinicians and providers face a virtual Tower of Babel, collecting similar data elements for reporting on different measures and measure specifications for different value-based purchasing programs and systems. The arbitrary variation doesn't serve patients, caregivers, or even payers or purchasers well, and diverts attention and resources from effective use of performance data we desire to improve healthcare and to assure the right care. We stand a better chance of getting to the right place, and I'm saying it will not be easy, by focusing on measures that matter, that deliver return on investment, and truly meaningful reporting on performance to help patients, caregivers, and payers and purchasers alike. Measures that matter is the right priority is set. I hope we can all agree that attaining the approach to measurement would mean that the promise of value-based payment could truly be met. Currently, I would posit the value-based payment is generally not implemented in a way that serves its purposes for the stakeholders, or when it does so in a way that's not sustainable. We measure for three reasons. First, to improve care, better care delivery and outcomes of patients. This is something that will benefit not only patients, but all the stakeholders. Second, to achieve accountability of health care to payers, purchasers, and patients alike. And third, for transparency, in order to produce meaningful, actionable information that includes understandable, timely data that can be used by caregivers to improve, payers to build better networks and calibrate payment, and patients to make decisions about their care. By focusing on these purposes I've outlined, we can better focus our measures on what counts and reduce the measurement creep that swamps quality efforts across the healthcare system. While it is true that all measures serve some purpose, all measures do not truly matter. Our main focus should be on the vital measures that result in real change and continuous improvement and serve objective assessment of care. Focusing on these purposes I've outlined would be best served by thinking of them in terms of return on investment. ROI is, of course, a classic business notion, but I think it adapts well to the performance measurement generally. Rather than thinking of ROI as a purely financial metric earned relative to the cost of an investment, here we stretch the meaning to include both quantitative and qualitative returns. In this context, ROI is time and resources, currency, and human capital that caregivers, patients, payers, and purchasers contribute to collecting, reporting, and analyzing the data, as well as the resulting improvement efforts. The return should meet my three measurement purposes for the most meaningful impacts on stakeholders: improved care, accountability, transparency, and usable information. Keep in mind that an important intangible of this investment should be peace of mind for the patient, something that is difficult to quantify, but is all too real for all of us when we are patients. This construct also reframes the current measurement discourse regarding burden. Burden is an important consideration that we should strive to reduce, but not reduce because of the burden, but because there's insufficient return from a particular measure. Beyond the purposes of measurement, we need to find a platform that will align the needs of stakeholders in their value-based purchasing programs. My experience with NQFs Measure Applications Partnership, MAP, demonstrates that it is possible to develop a platform to serve that role because it includes the key elements. The MAP process is a congressionally sanctioned, well-functioning, highly motivated, multi-stakeholder, private-public partnership that is driven by a consensus-based, transparent process with 6 years of experience grappling with measurement issues and working closely with CMS to determine measures that are best used for accountability purposes in federal programs. While MAP currently looks across the federal pay-for-performance programs, such as Medicare and Medicaid, I believe it is well positioned to work across all public and private programs and payers. This would require buy-in from a much broader array of stakeholders, including, for example, private payers, purchasers, and state programs. There have been some attempts at this, such as the informal CMS process with insurers, but those efforts did not include a self-sustaining structure. We need industry-led groups. These industry-led groups are fine, but on a larger scale, we need a broader participation of stakeholders, more formalized rules of the road, and increased transparency. In thinking through the purposes of measurement, the structure for accomplishing these tasks, we must also address the variation within the healthcare system among payers, caregivers, emerging innovations, and integrated delivery systems. That means not only using uniform measures to the maximum extent possible, but balancing the differences among providers with the ability to compare data across settings and systems. Aligning the use of measures across payers, what I referred to earlier as meaningful reporting, would reduce burden and help us move towards measures that matter and free up resources for caregivers to innovate on patient-centered care delivery. And so reducing burden doesn't necessarily mean less reporting. It does mean doing things such as facilitating useful electronic clinical quality measures where clinicians are able to easily pull the information directly from their workflow to inform patient care and streamline quality reporting. Honestly, what I've discussed today, measures that matter and assuring tangible returns on measurement, are not new notions. Many have discussed this, and that's really been the discussion this morning. With this increase in value-based purchasing across the healthcare system, it is becoming more critical that we embark on this path. Again, I didn't say that it would be easy, but a MAP-like structure and process, in my opinion, offers the best opportunity for success. If we agree on the goals of measurement, the need for a tangible ROI, and the process of moving forward, this could create a solid platform for the next, many would say, long overdue step, reassessing current federal payment programs to assure they align with the overall goals and work that already is being done in many states. So you see, there is much to discuss and future work to accomplish. It is important to begin now to pave the way, and I think the conference this morning and the discussions that we've already had have really set a good beginning for this new discussion. Thank you.
Good morning. I'm very honored to be part of this conference. I think the speakers have been uniformly outstanding, and really look. I want to reflect first on some of the things that I've heard today that are kind of mega themes. I don't remember who said it. It may sound weird coming from me, but measurement can't solve everything. That was a point I think Bob Berenson kept making. And it's really true. I mean, there are things that we measure through standards in our accreditation program because we can't actually measure them in a good way. So it requires a certain amount of nuance, of judgment, and so forth. So it's not black and white. Two, I think another theme that's come out of this is the danger, and it was you, Alan, that formulated the question so well. There's a danger of micromanagement by measurement and payment. Can somebody put my slides up? Okay. All right, thank you. There's a danger of that, and we need to be, I think Cindy said, humble about where we are with measurement today. And And really, I think one of my biases is that very narrow value-based payment systems give us the same fragmentation that we're trying to overcome. So we've got to be careful to have the payment model be holistic enough that there can be real trade-offs made, that things can be done outside of these narrow boundaries. I think it's very interesting to reflect on MACRA and the kind of bold statement that MACRA made, which was, okay, so if you want to be in fee-for-service, here's MIPS. It's kind of not going to be a lot of fun over here. It's going to be purgatory. And if you really want to be in an alternative payment model, life will be much nicer, but it's part of something that's bigger, with the exception of oncology medical home, I think, really, where I think you can really make the case that oncology is one of those specialties where when you have cancer, that is your medical home. And so I think that there are different kind of situations for different specialists, but I think the politics now are, wait a minute, specialists want to be in APMs too. They want that 5%. And now we're going to have this proliferation of, as Bob said, the left arm APMs. So that really will take us into a terrible place. So I think you're noticing I'm not talking about measurement so much. I'm talking about the context of measurement, which drives everything. Measurement, again, we're really kind of technicians here. We're plumbers. There's a broader architecture that drives the outcomes of the system in a way that is really very important. So let's go to my few slides here. A couple of big themes. One is we need to align the interests of the consumer or patient with the interests of the provider. I'm talking about the organized provider now, not the individual practitioners, with the interests of the plan and with the interests of the purchaser. So everybody's worried about money, everybody in a different way, but I think that, you know, the Hospital Stars program got a lot of bad press this morning. I want to say some really nice things about the Plan Stars program that CMS has. It's not perfect. We wish there were a lot of other new measures in it and so forth. But what it's done is it's given a clear story to patients about the quality of plans, and it's made the benefits walk over to the 4.5 and 5-star plans so that you get better benefits with the higher quality plans. There's been I think 11% lift per star in the choices that people make. And, you know, so we have people choosing higher quality plans, getting better coverage. They're not confused. I mean, they understand stars. They don't need to understand all the stuff underneath it. Providers, if they are paid in the right way, and I really am a fan of capitation, I'll use the ugly word, population-based payment, if you will. There are things that you can do when you have population-based payment or capitation that you will never do if you're in fee-for-service. If you have patients that are highly complicated, you will have care managers and a high-touch system that keeps them out of the hospital. That is not going to happen in a disaggregated system. So you really want the providers to be thinking about not what am I getting paid for doing this thing, but what does this patient need and how am I going to get their needs met? The plan, I think the plan already has incentives that are aligned with Medicare and Medicaid and private purchasers to a large extent. So what do we need next? We also need understandable choices for patients and for actually policymakers. I mean, when you think about all the things that are going on, let's go to dual eligibles. We have people that are in MA plans and a LTSS plan for Medicaid. We have people that are in classic Medicare and a LTSS plan for Medicaid. We have PACE plans. We have SNP plans. They all have different measurement logics, and at the end of the day, I don't know which policymaker can tell me which one of these is really working best if you go to the triple aim, which is the thing that I think has to remain our true north. Value-based insurance design. You know, there's a new experiment that Medicare has but people at the University of Michigan have been singing this song for a long time. We haven't paid attention to it, and I'll just go over to my other side there, which is underinsurance is not a value strategy, okay? Underinsurance means that, especially for the poorer people in the population, they will not go to the doctor. They will not take their medications. And I've seen data from a private exchange that looked at people by their income levels that showed very low use of PCPs, very low use of medications, very high use of emergency rooms. That is not a value strategy. It's not saving money. It is passing costs, shifting costs to patients, and really, really bad. And my final statement on this slide is, please stop asking consumers to solve our problems. We have a very complicated mess we've created here. Consumers are completely bewildered about it. They cannot solve our problems. We can give them information that allows them to use their agency in a constructive way that's a win for them and a win for the United States of America, that really has a problem with healthcare quality and costs, and for everybody in the system. I just wanted to show you these. I had our measurement people run these numbers for me because I just wanted to look at improvements over time. This is colorectal cancer screening, and I hope you can see the numbers. It's 66%. That's Medicare HMO at the top. And you can see that Medicare HMO is consistently outperforming Medicare PPO, commercial HMO, and at the bottom is commercial PPO with its high deductibles. So colorectal cancer screening, big difference between the different payment models. This is high blood pressure. Don't ignore that blip there. I think it's a function of a change we made in the measure. It's probably higher than this, but look at the spread between the Medicare HMO. These are, by the way, in the stars, and people work them very, very hard. And at the bottom, commercial PPO, 53%. So it's a 14-point difference in blood pressure control, which, is that an outcome measure? We can ask a lot of different people. Yes, it's an outcome measure, but it drives a whole lot of other more important outcomes like strokes, kidney disease, heart attacks, et cetera, et cetera, et cetera. So the context for measures will drive the success of measurement. That's my message today. Thank you so much.
Thank you. So my name is Niteesh Choudhry. I'm going to focus today a little bit on some of the more granular aspects of measurement. I'm going to highlight some things that we've talked about today, and in many cases agree with what other panelists have said, but in few point out differences, especially in contexts other than perhaps the hospital world where things are a little bit more evolved. So from a practical perspective, we could enumerate numerous different practical challenges with measurement, but I'm going to talk about 5 in the few minutes that I have. So first is which outcome, secondly is what data do we use, and what do different data sources tell us. Speed is a very relevant issue. How much data is enough? And then a concept which I'll call transparent analysis. So one by one, you've heard concepts already about which outcomes we measure. So our principle when we think about outcomes as a measurement scientist, so I'm a health services researcher, our outcomes should really measure actual value to stakeholders. We've now heard this 5 or 6 times today. And most relevant outcomes are unfortunately not easily observable. So Ashish did a nice job of sort of saying, okay, we can observe death, and that's true in the in-hospital setting. But as soon as you move out of the in-hospital setting, I'm a hospitalist clinically, that observing death actually becomes harder than it might seem. People actually die, but measuring death in a timely fashion, especially using commercial insurance claims data, is not so straightforward. And so we often lead to the use of process measures, many of which make a ton of clinical and economic sense, but as they turn out, tend not to always bear up to test of time. So think about hemoglobin A1C. We've learned lots about its association in some patient subgroups, not actually leading to better quality, in fact, perhaps leading to worse. The second concept I want to talk about from a measurement perspective is then, okay, let's assume for a second that we actually have a data outcome that we choose to measure and we think it's important. What data should we use? And the principle here is that data sources should allow for the efficient assessment of a broad range of quality measures. In this spirit, claims data, of course, is the backbone for a lot of what we do. Electronic health records have great promise as well, but unfortunately, none of these are comprehensive. So take the outpatient setting, for example. When we think about lab values, hemoglobin A1C, I'll continue to pick on that one. In a given EHR system for a given provider, there are only the measurements that are done in that system. And if a patient has more than one doctor or receives care in more than one site, including in the inpatient and the outpatient divide, no system in and of itself is comprehensive. And of course, none of these are measuring perhaps patient-reported outcomes or patient-centric outcomes, as we've heard numerous times today as well. The third aspect I wanted to hit on is speed. And here the principle that I would offer is that measures must be timely to actually help with decision making. So in a land of Medicare, that's great from the perspective of Medicare has all the data, but many routinely available sources, including claims, often have a lag. And so for data to be considered complete, it takes at least 3 months for that to happen, well into the next calendar year, after which you'd like to have made changes if you're working on an annual cycle. And manual data collection can be even worse. Survey data helps, of course, but getting enough survey data is even more problematic. This leads me to how much data, and here the principle that I would offer is that we should test differences or changes in value between providers with precision. We want to say, did this change actually happen? A basic statistical idea of sample size. But most providers have far too few events to test the statistical significance of many measures. So if you're a large hospital corporation, I think HCA is a lovely example of how this is possible. But think about now much smaller provider groups. And we heard earlier this morning about virtual provider networks. Perhaps that's a way to begin to address this with consolidation. But the point remains that for many providers and for many measures, we don't, frankly, have enough data. And it's even worse when we think about measuring cost. Cost data is very skewed, and sample sizes required to test actual differences in cost are much, much, much bigger than they are for quality-related ideas. And so how do we overcome the idea of any one provider not having enough data? The last idea I'll offer is what I call transparent analysis. And here the principle is that the parties to a contract need confidence in the approach that was taken. So most unfortunately, data analysis, including the stuff that I do, is somewhat opaque and not jointly done by interested parties. So we need some method to overcome this from a methods perspective. So this informs how the analysis is done, what's measured, and how it's shared. And rather than somebody reporting measures on their own performance and somebody else evaluating it, there's a joint party approach that perhaps could take this forward. So all of these are sort of challenges, and I've phrased them that way on purpose. And perhaps just in the spirit of providing a little bit of optimism, I think there is actually ways forward in all of these. And so what I've sort of indicated here are at least my perspectives on the things that are easiest for us to fix. So the idea of what data perhaps is near the top of this list. We heard about EHRs, and I am also a great believer in the ability of EHR data to actually help us in some domains, but even better integrated data, EHR claims other sources of data across settings, even retail pharmacy data, for example, or healthcare data from other healthcare settings, which we typically don't think about. I think that should be an easy problem for us to solve. Speed should also be an easy problem for us to solve. This is either the lags that we do have, which is mostly comes from provider services, is a result of how long it takes many providers to actually submit those claims, and then for insurers or other payers to actually process them. That's a surmountable problem as well. So I think that's high on our list. Transparent analysis is also solvable to the extent that there are platforms which allow for commonality in creations of study cohorts and an actual running of analyses, so to share the idea that these data actually might be useful. What becomes much harder, but I also hold promise for, is which outcome and how much data is enough. And those really require structural or conceptual changes. So that said, I look forward to the discussion. Thanks.
Great. It's wonderful to be here with you today, and I feel like I've been wrestling with this challenge of measuring quality and value for quite some time. First, in state government, when I was trying to figure out how to incorporate value into our value-based payment programs, and I think I'm not the only one that often found myself reaching for a familiar set of HEDIS measures as the path of least resistance. I'm also a primary care physician, and in that role I work with patients who have very significant health and social challenges, and I struggle in my practice with how distant our system of measuring value is and feels from my day-to-day work with patients. And finally, I run a policy and advocacy group that's focused on elevating consumer voices as what we see as the North Star for delivery system reform efforts. And in that role, I've really tried to support consumers, consumer advocates, and leaders to participate in quality measurement efforts. And I would say I've had pretty limited success. But, as they say, the dawn comes after the darkest night. So despite my lack of success to date, I remain hopeful that there's a way forward. And actually, could you put my slides up? Oh, do I know how to? I didn't realize I had the power. Let's see. Yep. There we go. Okay, so that's me. The challenge with quality measurement and this paradox that I think Chip alluded to today of having too many measures yet not the right measures, I find it easy to explain with an analogy, and that is that of a car. So if you are manufacturing a car, you need to know thousands of things about that car. How long does it take to weld two pieces together? What's the variance and the milling of a particular part? But if you are the person who's buying that car, you want to know a totally different set of things. You probably want to know the price. You want to know the fuel efficiency. You might want to get a sense of are other customers satisfied with that car. And these are two distinct sets of measures. You'll notice that they are both very, very important. I'm not saying the production measures are not important. They're very important, and they're a measure of quality. But they're fundamentally different than the measures that consumers are using. So the challenge in medicine that we have hundreds of production measures, and we have very little understanding of the consumer measures that we need. So in my mind, this presented a somewhat obvious solution, which is get consumers to develop the measures they want. And unfortunately, I had not heard Peggy's talk when I came up with this idea, and she could have warned me that this is not as easy as it seems. So we tried to work to support consumers who are engaging in different aspects of quality measurement, and pretty much failed at it. And actually, I failed so badly at it that I asked two researchers from the RAND Corporation, Tom Concannon, who is an expert in patient engagement, and Mark Friedberg, who has expertise in performance measurement, to study why we were having such a hard time. And so Mark and Tom worked with us to convene consumer roundtables with advocates who'd had different degrees of engagement in quality measurement. And we asked them a lot of questions about their experiences with engaging in quality measure development. There are a number of themes that emerged. There is a full report, and I'm just going to go over a couple of quotes that emerged from these conversations with consumers. So the first one is this phenomenon that we labeled unequal power, which for those of you who've ever been on a multi-stakeholder coalition, and there's about 35 people in the room, and there's 2 or 3 consumers, and they're expected to represent the voice of all consumers in the room. And one of the advocates who'd been in the situation noted, if you have people who are paid to be at the table and they're professionals, and the community members who are there do not have the same resources, it appears that the community is there, but the power dynamic wasn't balanced. And this is a theme that came up multiple times. A second theme that comes up is this idea of limited menus. This happens to a lot of us. There's a whole life cycle of measure development, and oftentimes consumers are asked at the level of, for example, a state program where they're asked, here are the bunch of measures that you can pick from. Why don't you tell us which of these you want? And the challenges we've laid out is if you have only production measures, consumers might legitimately say, none of these are right. And then the conversation is, well, there's not a validated measure, so, pick one of the ones that are on the list. This has been another challenge for consumers, a challenge for them feeling like the engagement is fulfilling or useful. And the last quote I'll leave you with, is one that we called flat-footed. This is from a consumer advocate who talked about how she felt like they were in meetings and there were words being used in these meetings that they never heard before. So she's trying to Google them on her phone so she can participate in the conversation. So this is an area where people feel under-resourced and there's a need to build technical expertise among consumer groups. So having spent this time, trying to figure out how to improve consumer engagement, we've really come to the conclusion that what we need is an infrastructure for consumer engagement. For me, I'm particularly interested in the voices of consumers like those that I serve, those who are marginalized, low income, non-English speaking, with complex medical conditions. What do they think of as quality, and has anybody ever asked? And in order to engage consumers in this way, particularly from those communities, I think the infrastructure has to be nodal. I think we have to get away from plucking a consumer and popping them on a technical expert panel and feeling good about ourselves, and then they disappear into the ether when that commission is done. We need to think about, this actually came up from one of the consumer advocates who participated in the roundtables, who said of researchers, quote, "They zoom in, do their study, and zoom out. If you really want to develop meaningful quality indicators, develop sustained relationships with consumers." So we're very interested in creating consumer engagement that's grounded in community, where consumer leaders can support each other as peers, and where they can also tap input from a broader group, not just from their own individual experiences and opinions. And I think that this infrastructure for engagement is what we'll need to get us to the consumer-oriented quality measures that we need in healthcare.
Okay, I promise I won't run out the clock this time, but I'm going to ask, so I'm going to keep I'll start with one question. I've got a few on hold, depending on where you all go. Peggy, you completely accurately closed by noting that the context drives the value, and of course the whole morning was about context, so my hope is that the three panels together come in to take the technical side of measurement as well as the context. I want to pose two hypotheses and ask all four of you which of these you think is closer to reality.
Reality or what should be?
Reality. You can opine on what should be as well, but I'm more interested, I guess, in reality right now. One is that we have a lot of micro activity going on in measurement and in payment. And they are the likely result of all of those micro developments of understanding of measurement, as well as some of them tied to payment, many not, is to improve lots of parts of the system, including how we treat pain, left arm pain. And that is a useful platform for the kind of comprehensive system integration, patient-centered, coordinated care that we want. The other hypothesis is that the best efforts to improve the quality from the perspective of the patient in the end comes from integrated systems that draw data from within, have the sophistication that we've heard from some of the people who spoke here today, operating in a fairly unfettered environment, and they develop their own methods and processes within their system, and if they have to spend a bunch of time participating and calibrating to all of these micro examples that are underway, that's really a diversion. And it's at a minimum a waste, and at maximum it's actually counterproductive to the kind of integration we want. So I'm trying to ask the question, given that not every patient and not every clinician is in an integrated system, is the investment in all of these little things helping us migrate to a better coordinated system, or is that sort of a fool's errand and a diversion from what's really needed to get the clinical systems and the patients into integrated systems? Which of these is more how you think the value can be pursued. So it's a normative question, not just descriptive. Peggy, you seem ready to go.
Yeah, I think it depends, of course, on the context again. I think, if you listen to what John was talking about, and if you see what other integrated systems are doing, it's kind of rocket science sometimes. And we want to encourage rocket science. And at the same time, we have to be able to say to Medicare beneficiaries and to people, you can get decent care here. And so we're kind of caught in a quandary. I think if we think about it as who's running the system and who's buying the product. I mean, if Medicare, ideally, in my mind, would be buying the product. But when you get into all these little micro things, Medicare winds up trying to run a system that doesn't work. And I think that's the dilemma. We're not going to have integrated systems everywhere in this country in my lifetime, for sure, if ever. So I think we have to live with a certain amount of contradiction around this question. But I think what we want to do is make the path easier. If you want to be a rocket scientist and can prove that you're doing it, then we want you to be able to succeed. And I think that requires advantaging people that are doing a great job. I loved Ann's distinction between consumer measures and production measures. I think a lot of this is about production measures, actually, which we take for granted. But, yeah.
Let me look at this from a different perspective. I think, and I've been part of this great, over my career, particularly on Capitol Hill, this great reform imperative that we've had, probably starting with Carter cost containment, which failed, and then DRGs and the rest of the development. And frankly, as smart and aware and informed and as hard as they work, the people that come up with the policies frequently don't have their feet on the ground. And I think that's what, and then when the policymakers pass a policy, enact a policy, it tends to be non-dynamic and of the moment and rigid. And what we're suffering from, I think, in Medicare is the imperative that we've got to make Medicare value-based. On the other hand, so now we're stuck with a 2010 model that was in ACA, value-based purchasing, readmissions, and the HAC program, which has a horrible enforcement mechanism. And CMS, as much as they try, are stuck with this framework. And so it's great to talk about how we're going to transition to some kind of more dynamic system, but we're burdened with a policy for, I guess, our second largest program now, since Medicaid has more people covered. For our second largest program, we're stuck. And so all the discussion this morning was around, gee, this needs to be more dynamic. And frankly, if you listen to some of the comments about MACRA, MACRA doesn't help. It may be a little bit at the margin, but probably not even much in terms of alternative payment models. So frankly, one could get depressed pretty quickly when you think that we're stuck in the mud in an area where the thinking has gone way beyond. And I must say, I'll conclude with this. I won't mention his name, but the chairman of, one past chairman of NQF once said to me that, all this reporting stuff that we have to do for Medicare is great, but, back at my place, the quality shop has their own metrics, and we have to do all this stuff for compliance, but that's not what we do to make sure that we're providing real quality in our institution.
I'll just say, I have a, radical suggestion. I used to practice in an academic medical center with Niteesh, and I now practice in the community. And I would say in a small community practice, there are just so many layers of duplication and complexity. And my question is there any way to address this on a community level? Is there a way to change culture, practice, healthcare on a level that's grounded in the community? Because you might have 12 different payers and 50 different measures, but you have the same resources. It's the same hospital, it's the same community-based organizations, it's the same primary care doctor trying to make this work. And is there a way to shift our frame away from the layers of who's contracting with who and shift it to one that's grounded from community?
So Ellen, you offered us two hypotheses. So I'm going to agree with both and disagree with both. And I'm an academic.
This was not an option.
Yeah, exactly. I was a high school debater. I'm rewriting the rules. So I think, optimally speaking, we want, a learning healthcare system, one that is able to innovate and create and measure and produce results, like some notable examples we've seen today and elsewhere. And there are nice examples of this. I spend a lot of my time working with large health insurance systems, implementing studies and randomized studies and using routinely collected data to evaluate their outcomes. But those are still rare, and they're a fraction of all of the evaluation that could be done. And so to the idea that what we're doing now in large integrated systems somehow represents the standard, that's true, but it's not necessarily the full standard that we would aspire to. To your first hypothesis that, hey, look, all these little measurement things that are then being inflicted upon less integrated systems, that those are somehow problematic. I think I agree with that idea. But there's something about measuring that has another effect, which we perhaps haven't talked about. So there's the burden, that's bad. But there's the idea of kind of looking, which is good. And the idea that, hey, look, there's something that could come useful from this data. It might actually inform care, notwithstanding the fact that it actually hasn't so far, but it could. And so there's a culture of, the offer was made, I think, by Ashish of quality improvement, almost like PDSA. Well, there has to be a measurement there. And so engaging frontline providers in the process of saying, okay, how do I make it better, is like providing them with the tools to do so. So I'd say both of your hypotheses are probably right.
Just one last word. I feel like we're really torturing individual practitioners for little gain. I think when you have a system, the system can support the individual practitioners, and they're not having to say, did you have your mammogram, and so forth. I mean, there are a lot of things that a well-functioning system can take off the to-do list of the practitioner, and those things should be happening. But there are a lot of really dumb things happening, right? With each of us having our own measures, having the same measure, the same issue measured differently at the plan level, the ACO level, and the practice level is inexcusable. I mean, if the clinical logic is different. So we need to straighten this stuff out. But I think ultimately, and I think virtual systems are coming. We can have more of that takes off the plate of the practitioner the kind of hamster wheel stuff that they hate so much.
I have more questions, but I didn't give you all a chance in the second round. Yes, please. We'll get a microphone to you momentarily.
Hi, good afternoon. My name is Katie Rote, and I'm with Bates White Economic Consulting here. And as I've been listening through the panels this afternoon, or I guess this morning, it seems like there is a great understanding within the healthcare community on a variety of different factors that want to be taken into account when evaluating quality within the healthcare industry, whether it's on the physician side and considering the differences between specialty care versus primary care, or socioeconomic status affecting hospitals. So it seems like there are a wide variety of factors that want to be taken into consideration, and with that comes a lot of data analysis and data collection. But as I've also heard today, it sounds like physicians and hospitals are already overwhelmed with doing a lot of paperwork and taking into account a lot of data already. So when we're coming up with these quality-based programs, how do you suggest we balance wanting to have a robust evaluation of quality, but at the same time not overwhelming physicians with having to collect more data or using our limited resources in collecting data rather than helping the patient directly?
It's the $64,000 question.
So I'm happy to wade in. So I think that's a great question, right? And that underlies a lot of what we were talking about, which is burden. So as a frontline provider, I totally get it, and I have the privilege of working in a hospital where all the work is done for me, but that still doesn't sort of excuse the idea that there aren't lots of these measures, and Peggy's points are 100% well taken. I think my answer to your question is that increasingly data and analysis of data is a commodity. So think about writing a thesis. When you were a doctoral student 40 years ago, you used to literally take a typewriter and type it out, and if you made a mistake, you used to retype the pages, or so I'm told. So when I was a doctoral student, 10 years ago, 15 years ago, it's a little bit different already. And so the idea of word processing as a commodity has made a reality for us, and now we word process on our smartphones. So data analysis is actually coming the same way, right? There's lots of parts of this which become plug and play. Now with that plug and play become responsibilities around what you're actually doing with the data. But I think the answers around both the ability to do analysis, we heard earlier today about NLP, are ways to extract information, other sort of ways to do, for example, machine learning, which is just another form of asking hypotheses without sort of needing to program statistical code, are increasingly commoditizable. And in the next couple of years, with the advent of these tools, of which there are now many, 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 hopefully the burdens, at least, of extracting the information and then performing robust analyses become more of a plug-and-play kind of problem.
But going back to my remarks, I think at the end of the day, that hopefully is true. We're still going to have some structure, and to meet the sort of mandate that Peggy raised of the variation, to do away with that variation, we're going to have a structure where some entity, hopefully, that brings people together, all the payers, and doesn't have the rigidity of the U.S. Congress, or frankly of Baltimore, of CMS in Baltimore, because they have to do whatever they're told in the law, can work this out so that we have some kind of dynamic scheme where you're only asking for what's really essential, and everybody's being asked. Clearly there's going to have to be some variation for different conditions, but everybody's being asked the same things, at least in terms of the underlying specifications, so everything's comparable. Otherwise, we're going to continue with something, and it's going to get worse, of a system that's going to be very, very inefficient, because, as was pointed out, people are now being asked different things by every payer they come in contact with, and there isn't any kind of mechanism to bring together. One size doesn't fit all. On the other hand, if there's not coordination, no size fits any.
I would just add that I wouldn't, take your eye off the prize of those, handful of consumer-oriented measures. 10 or 20 production. It's not there's not like an algorithm of if you have 10 production measures, that's as good as one consumer measure. Just remember they're just fundamentally different things, and I think we need to keep our eye on that direction and make sure we're moving towards that parsimonious set of consumer-oriented measures.
Hey, yeah.
At the risk of alienating some of my friends, I just want to say that this social determinants question, I think, is something that I struggle with a lot. And while it may not be our intention to adjust away differences, I think the impact of some of the risk adjustment actually does exactly that. I think healthcare can't solve social inequity, and we have growing social inequity. So that's a reality and a terrible problem that we all live with. But I think meeting the patient where they are, that is the essence of the healing process. And that means where they are as a person and not just as a biological entity. So I struggle, and I call to your attention Dana Safran's great paper that was in the New England Journal showing that their safety net providers were doing an equally good job, or actually improving quality faster. So I wonder if there isn't something about improving quality as another factor that could be put in place for safety net providers, or providers that have a particular burden of social inequity that they're dealing with. I just put that out there. So I had to say something.
So I'm going to take one here in the back, and then I'm going to ask the last question.
Hi, my name is Allison Silvers from the Center to Advance Palliative Care, and putting the comments from this morning, especially Dr. Goodrich saying that individual clinicians want the measures to reflect their own performance, and that makes sense. If you're accountable for something, you want it to be in your control. And yet this question of systems and system level and virtual groups, I'm just trying to wrap my head around it. It seems like one of the big barriers is the accountability at the individual provider level, and I'm just wondering if you have any powerful ways to break out of that barrier.
I feel like this is, I think, such a big problem. And, it depends on what the doctor is doing, right? I mean, if you're a proceduralist and you're really good, I mean, I don't know if any of you saw the videos of bariatric surgery that John Dickinson was showing, that showed very noticeable to the lay public differences in surgical techniques that absolutely predicted outcomes, et cetera. There are things that doctors do that matter a whole lot. There are other things that doctors do that can be delegated within a system. We need to separate those. I think the medical boards, they've been taking a lot of heat for trying to say, are you up to speed? Is your performance up to speed, et cetera? But they have their place, and individual enterprises also need to be evaluating the people that work in them. But I think that's different from having, stars for individual doctors coming down the pike, which I don't believe is going to happen, but I know that's still on the plan, right?
Yeah, I think it's very difficult because, the attribution issue is never going to be solved in some way because, some people have teams, but when you get really sick or have a combination of illnesses, you tend to be treated by a number of different people.
Right.
And that's just the reality of how care is provided. That being the case, this notion of attribution becomes really, really difficult, except for, the cold when you go to the primary care doctor. Your primary care doctor is for people for the 5% of people who are really sick, where most of the cost is, who really matter, attribution becomes really a big problem, and that's where all the money is, as well as hopefully the value, because those people really, need whatever the system's going to give them.
Yeah, but that's why you need a system around those people most of all.
Yeah, I think it's the team at the end of the day. It's got to be a team.
So maybe just another way to sort of think about the question is about why people want to be measured on what they do. And I wonder if that's a reflection of the fact that we have promulgated a number of measures, and then people say, well, that doesn't apply to me. And so the problem in that case is actually measurement, or the nature of the measurement. And so where these two things come together is that most doctors want patients to feel better, for example. Most patients want to feel better. Most patients, I agree with Ashish, that most patients don't want to die in the hospital. And so there are measures which are common to an electrophysiologist as they are to a general internist and across specialties. So what we have ended up with may have been a force to, well, that doesn't apply to me, rather than I'm actually trying to measure something that makes a difference.
My lens on this is what would the patient want to know, right? So if your doctor is a doctor that performs well on doctor-specific measures but practices in a system where there's lots of gaps in the coordination care, what is that helpful to that patient in making any decisions?
Okay, so I'm going to close with a tortured question, but it's so tortured your answers will be quick. And I was really, I also was really struck by the engineering for the inside and for the consumer, the sense that engaging consumers in the technical development process is very difficult because it's not their world. And then there's this whole world of consumer products in our culture that invest phenomenal amounts of money in understanding the consumer experience. Their business case for doing so is that they're selling a product, and if they do a good job understanding what consumers want, they'll sell successfully. We have an enterprise where we have a single or very small number of purchasers. They're defining the product, so the consumer is sort of an afterthought in that, which led, I think, to Ashish's notion of, well, let the consumer have some dollars, and that would change the dynamic. But then, Peggy, you also pointed out that underinsurance isn't a value strategy. In theory, consumers, if they don't have insurance to cover costs, would be another pool of people to define and reward value because it's their money, to the extent they have any. So my question is, how do we take Ashish's bold idea and use it as a platform for improving our understanding of what consumers want and improving, and I think this is the key question I have, improving how the health sector and the public sector think about measuring and engineering the healthcare sector to really go after what consumers want, not just to come up with 4 more consumer experience of care measures, but how do we use his way of thinking to lead us to a different way of thinking about how to get consumer experience into the public policy formula and the health system formula? I told you it was going to be tortured.
Well, I mean, I'll tell you about an experience that I had, about 2 years ago. We did consumer focus groups on shared decision-making for people with cancer. And we did men, and it was, advanced stage cancer, women with breast cancer, men with prostate cancer. I think there were differences between men and women. The women were much more worried than the men. Well, no comment. But what was really striking was this desire to trust the doctor. And this desire that I picked the best doctor, which of course, I don't know how they knew that because they don't have the information. I picked the best doctor, therefore I want my doctor to tell me what I want, and I don't want to get too involved with this. And there was one place that we went to that really was totally committed to the concept. They had navigators and everything. They finally got the patients to kind of be willing to express some preferences. But this was it was grant funded and charity funded. It's not realistic. So I think that this question of what consumers want, under what circumstances, is a very powerful and complicated question. I forgot my second point. So I'll just drop it.
I guess I don't agree with that last point. I think what consumers want, and Ashish really made it clear, is they don't want to die and they want to get better. They want those two things, and they want to have as little interaction with the system as they have to get better, because because healthcare is usually pretty unpleasant, and it's not where you want to spend your time. So that's pretty simple, and they want to be treated with dignity, and they want to feel like, and frankly, it's the same with pensions and mutual funds. Most people don't want to spend a lot of time figuring out how to invest their money. They want to be able to go to somebody who, Fidelity or whoever, who's going to take care of their money and make sure that there's enough when they get when they need their money when they retire. So I think I think we spend, there are decisions that have to be made, in cancer therapy or in these other therapies, but it's pretty simple what people want. The trouble is that the system, even at its best, can't get them there necessarily, because we can't cure everything, and we all have a chronic condition, which is life.
So this kind of.
I think we should just stop right there.
No. So I'm saying I think we have, as long as we keep it that simple, we can, people can tell you what their preferences are, but you got to keep it that simple. And the trouble is, this is where the doctors, getting that doctor-patient relationship really is key. And maybe it's patient-team relationship in the future, but that's where, just like the people at Fidelity hopefully are responsible, the people in healthcare team or that individual physician needs to be responsible. Well, that's the dilemma.
Yeah.
So this reminds me of when I was in high school and I got into a conversation about The Godfather, and then halfway through I had to confess, I've never seen The Godfather. So I was not here when Ashish spoke, so I think I gathered enough from this conversation to interject, but I'm just gonna come clean and say that up front. So I just wanted to, to add sort of a footnote to Chip's comment, which is that there is a population of patients, including the population of patients that I work with, who are forced to interact with the healthcare and community-based services, system, and probably have a little bit of a different perspective. People who depend on long-term services and supports, who have high needs or very complex care needs. And I think we just need to remember that for that population, there actually has been some good foundational work about what is important to folks who use LTSS. The question is, how can we push that into measures? So just not everybody is exactly the same, and just wanted to add that, and hopefully that was somewhat on topic.
So maybe just one last idea, Ellen, that to some extent what you're describing is almost what I would think of as the paradox of empowerment. That the ability to measure, or that the ability to have your voice heard, while in and of itself that's a social value, but that doesn't necessarily always lead to the healthcare system delivering what you want it to deliver for you. If you want to not die, that's a clear voice, and being able to sort of contribute to your not dying doesn't necessarily guarantee that you won't. And so I think that I don't have an answer to your question, but this idea that we need to measure things because they're important to measure is different than whether that measurement will actually achieve the ends that we hope.
Well, let me just close by saying that I have found the conversation all morning quite engaging. I'm struck by how much the conversation has evolved just since we had this event on a similar event less than a year ago. But if you think back 5 years or 10, it's a completely different world. I'll just note three types of evolution that stood out for me. One is that we aren't really questioning whether measurement is necessary, or the resistance to measurement seems to, people have been beaten into submission, let's just say. But the need for measurement is now inherent in the discussion, and I would say that was not the case not terribly long ago. Second of all, there's a lot of optimism about new sources of data and speed and uniformity and analytics that have always seemed just around the corner, but I think are now in use in leading locations in a way that we did not see very recent, not long ago, and that also opens up new opportunities. And finally, I have always felt, and I think this panel really sealed the deal for me, I've always felt that in quality conversations that I've been a part of for at least 2 decades, the question always begins with, what are the gaps and how do we fill them? And what I hear now is, what are our goals and how do we achieve them? And it's just a very different way of thinking about it. And I think that's a very encouraging development. So please, thank you for sticking with us through a long morning, and please join me in thanking our panel.